Selamat pagi Bu Direktur yang juga sudah hadir.
Halo, Assalamualaikum Pak Fikri, Bu Widi,
Waalaikumsalam. Ya, Bu
Rahma,
Pram.
Bapak Ibu semua.
Siap.
Mau
Izin
kita
dimulai Bu
mulai
Pram.
jam berapa?
Ya, baik.
8.15 Bu, kita sudah terlewat 2 menit. Kita mulai sekarang Bu.
Ya, boleh.
Ya, siap. Mohon panitia dan MC untuk bisa memulai kegiatan. Silakan, bisa dimulai kegiatannya. Operator, monitor.
Oke,
Ya,
siap Pak Wadir. Terima kasih banyak Pak. Coba disampaikan ke tim. Oh, sebentar Pak Wadir.
Ladies and gentlemen, may I have your attention please? Our session is about to begin. Thank you. Good morning, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. Peace be upon you.
Waalaikumsalam warahmatullahi
We are
wabarakatuh.
delighted to welcome you to the 8th International Conference, Interprofessional Collaboration and Community Empowerment. My name is Rumita. I'm very honored to be your Master of Ceremony for today's event. to the Honorable Excellencies, Director General of Health Human Resources, Ministry of Health of the Republic of Indonesia, Director of Poltekkes Kemenkes Bandung, the Honorable Speakers, the Honorable Moderators, Project Officer, and Committee of today's International Conference, Honorable Lecturer and staff of Poltekkes Kemenkes Bandung, Excellencies, distinguished guests, participants, ladies and gentlemen. Praise and gratitude, let us pray to God Almighty. For every seat that has been filled here is only because of His guidance and
Dan
wisdom.
kadang nyari
May
tersebut
this
di sini juga
international
ada
conference
tujuan
be
dan
a
manfaat kita
meaningful
untuk
discussion
membahas
for
dari
all
norma
of us.
farmakologis ini,
Ladies and
yaitu untuk
gentlemen,
menambah
today's
pemahaman
international
tentang
conference
nyeri dan tata
is
cara
held by
penanganannya. Lalu,
Poltekkes Kemenkes Bandung with topic Building Global Health Resilience through Interprofessional Collaboration, Sustainable Solution in Type 2 Diabetes Mellitus Care and Community Empowerment. This conference to bring together academicians, researchers, students, practitioners who are interested on preventing and managing diabetes mellitus through interprofessional collaboration. This conference provides a great opportunity for participants to gain our knowledge in terms of managing diabetes mellitus through community empowerment. This conference will feature presentations by international speakers, which are cutting-edge session topics. Ladies and gentlemen, today we will have 6 amazing topics that will be delivered by 6 speakers. The topic will be divided into the morning session and the afternoon session. Make sure that you will stay with us until the end of this conference. Ladies and gentlemen, before progressing our agenda, let me read our event rules as follows. Our event will be held for 2 days, 22nd and 23rd October 2025. The first agenda will be consist of the main session in the morning, followed by the plenary session. The second agenda will consist of the expert session and the conference. Participants can join this international conference by using Zoom Cloud Meeting platform for the first 500 participants, and for the rest participants can access it through our YouTube channel, Media Poltekkes Bandung. Participants are required to rename the Zoom account into country_real name during this virtual meeting. For example, Indonesia_Sumita. In order to get the certificate, participants should attend the first and the second days of the conference. Participants should fill the attendance, evaluation form, and post-test in Pelataran Sehat. Participants are requested to deactivate the microphone during the session. Thank you for your attention. Excellencies, participants, ladies and gentlemen, we are now going to listen to report speech that will be delivered by the chairman of today's international conference, Apotheker Diki Bahtiar Purkon, MSc. Ladies and gentlemen, please welcome Apotheker Diki Bahtiar Purkon.
Nah, okay, thank you, Mrs. Dr. Sumita. The 8th ICI 8 CCE 2025 marks another milestone for Poltekkes Kemenkes Bandung in advancing interprofessional education and collaboration, IP or IPC, within healthcare, practice, research, and community empowerment. This year's them emphasize the importance of global health resilience through sustainable collaborative efforts, particularly in addressing type 2 diabetes mellitus as one of the world's most challenging non-communicable diseases. The conference is jointly organized with REACH Universitas Airlangga as co-host and brings together international speakers from Finland, Malaysia, Brunei Darussalam, and the Philippines, alongside distinguished experts from Indonesia. Participants from diverse disciplines, midwifery, nursing, nutrition, pharmacy, dentistry, public health, dental health, and health promotion share insights, experiences, and innovative approaches that highlight the value of interprofessional teamwork in strengthening community-based health resilience. The outputs of this, prompter. Okay, and innovative approaches that highlight the value of interprofessional teamwork in strengthening community-based health resilience. The outputs of this conference include scientific publications in nationally accredited SINTA 2 and SINTA 5 journals for selected paper, international proceedings, and ISBN with co-host CV Media Science Indonesia, and collaborative recommendations for advancing interprofessional education in health institutions. The organizing committee extends sincere appreciation to the Ministry of Health, Director of POLITEKNIK Bandung, all speakers, reviewers, and partners for their dedication and contribution to the success of this event. Together, we reaffirm our shared mission, collaborating across professions, empowering communities, and building a resilient global health future. Thank you.
Ladies and gentlemen, I would like to invite you to sit properly to listening Indonesian national anthem.
sebagai pedoman kami, membangun hidup berdiri tak pernah henti untuk Indonesia tercinta. Poltekkes Kemenkes di Indonesia siap mengabdi nusa dan bangsa, berbudi luhur, berakhlak berbudaya, berbakti demi tugas mulia. Poltekkes Kemenkes di Indonesia bekerja profesional dunia, semangat juang tak pernah padam untuk kesehatan bangsa. Siap melangkah untuk berbakti, Sri Dharma sebagai pedoman kami, membangun hidup berdiri tak pernah henti untuk Indonesia tercinta. Poltekkes Kemenkes hebat, Indonesia sehat.
Thank you. And now we would like to invite the Director of Poltekkes Kemenkes Bandung, Dr. Pramita Iriana SKP I'm Biomed, to give her welcoming speech. Ladies and gentlemen, please welcome Dr. Pramita Iriana SKP M Biomed.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
Assalamualaikum
warahmatullahi
warahmatullahi
wabarakatuh.
wabarakatuh.
Waalaikumsalam
Good
warahmatullahi
morning and warm
wabarakatuh.
greetings to all of you. Our most distinguished guest, Director General of Human Resource for Health, the Ministry of Health, Republic of Indonesia, Dr. Yuli Varianti MPit, Honorable main speakers, distinguished guests, esteemed colleagues, researchers, practitioners, and all participants from around the world. On behalf of the entire academic community of Poltekkes Kemenkes Bandung, it is my great pleasure and honor to welcome you to the 8th International Conference on Interprofessional Health Collaboration and Community Empowerment 2025. This annual conference has become a platform for sharing knowledge, research finding, and innovative practices in the field of health. Our commitment remains clear to strengthen interprofessional collaboration as a foundation for improving global health outcomes. This year, we gather under the theme Building Global Health Resilience Through Interprofessional Collaboration, Sustainable Solution in Type 2 Diabetes Mellitus Care and Community Empowerment. This theme is both relevant and urgent. Diabetes mellitus continues to be one of the world's leading health challenges, demanding not only medical solution but also collaborative, community-based approaches involving doctors, nurses, nutritionists, pharmacists, and public health professionals. We are deeply honored by the participation of our distinguished keynote speakers and the support of the Ministry of Health represented by Dr. Yuli Varianti MPit, whose leadership continues to inspire effort in strengthening our health workforce. I would also like to express sincere appreciation to our strategic partner and co-host, the Advancing Community Healthcare Research Center of Universitas Airlangga. This partnership expands the impact of our work and ensures that the outcomes of this conference, through meaningful discussion and scientific publications, will contribute significantly to improving community health. Ladies and gentlemen, I hope this conference will not only serve as a venue for presenting research, but also as a dynamic forum for exchanging ideas, building networks, and fostering collaborations that translate into real-world health solutions. Let us take this opportunity to learn from one another to reaffirm our self-vision of a healthier, more resilient global community. Before we proceed to the next agenda, it is my great honor to invite Dr. Yuli Varianti MEPIT to kindly deliver her remarks and officially open this conference. Thank you, and may this conference be fruitful and inspiring for us all. Wassalamualaikum warahmatullahi wabarakatuh, and good morning.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Dr. Pramita Iriana, for the warm welcome speech. Ladies and gentlemen, we are now continuing our meeting to the next agenda. To know more about Poltekkes Kemenkes Bandung, we will glad to inform you about video profile. Please welcome.
Politeknik Kesehatan Kementerian Kesehatan Bandung, or Poltekkes Kemenkes Bandung, is a state vocational higher education institution under the Ministry of Health of the Republic of Indonesia. As a strategic center for health education, Poltekkes Kemenkes Bandung is dedicated to producing professional, ethical, and globally competitive healthcare professionals. Poltekkes Kemenkes Bandung is located at Jalan Pajajaran number 56, Bandung City, West Java. Bandung is known as a cool and comfortable educational city. Our vision is to be a leading health polytechnic, excelling in applied technology, character development, and global competitiveness. This vision guides our every step as we grow and contribute to healthcare, both nationally and internationally. To achieve this vision, Poltekkes Kemenkes Bandung is committed to 7 core missions. First, provide high-quality education aligned with global orientation in applied health science and technology, producing graduates of strong character. Second, conduct innovative applied technology-based research that leverages local resources and wisdom while empowering communities. Third, implement innovative community service initiatives that have a broad impact using research to strengthen quality education. Fourth, foster partnerships with national and international stakeholders for mutual progress. Fifth, develop new educational programs to meet the evolving demands of health science and technology. Sixth, cultivate an integrated and ethical workforce to ensure good and green governance, operating with transparency and accountability as a public service institution. 7. Lead health transformation by establishing a center of excellence for diabetes mellitus education, integrated into our core academic activities of teaching, research, and community service. Poltekkes Kemenkes Bandung has the following human resources. Poltekkes Kemenkes Bandung offers a variety of academic programs designed to train competent healthcare professionals. Our departments include the Department of Nursing, the Diploma of Nursing program in Bogor, Department of Midwifery, the Diploma of Midwifery program in Bogor, the Diploma of Midwifery program in Karawang, the Department of Environmental Health, the Department of Pharmacy, the Department of Nutrition, the Department of Dental Health, the Department of Medical Laboratory Technology, and Department of Health Promotion. Those campuses are spread across several cities. Campus A is in Bandung. Campus B is in Cimahi. Campus C is in Karawang. And Campus D is in Bogor. Poltekkes Kemenkes Bandung achieved the highest 100% competency test pass rate in 2024 at the national level. Students and lecturers at Poltekkes Kemenkes Bandung not only excel in academics, but also actively excel in various activities, including research, student organizations, community service, and local, national, and international competitions. The numerous awards they have won prove their strong competitive spirit and ability to bring recognition to our institution. To support a comfortable and innovative learning environment, Poltekkes Kemenkes Bandung provides various facilities, including interactive classrooms, modern laboratories, a library, a network of partner hospitals, sports facilities, and student dormitories. These resources are designed to help students grow holistically.
As the director of Poltekkes Kemenkes Bandung, we remain firmly committed to upholding educational quality, driving innovation, and making tangible contributions to the advancement of national health. Through education, research, and community engagement, we are confident that Poltekkes Kemenkes Bandung will consistently produce generations of healthcare professionals who demonstrate integrity, excellence, and competitiveness at the global level.
With a clear vision and focused mission, Poltekkes Kemenkes Bandung is ready to produce professional, ethical, and highly dedicated healthcare professionals. Together, let's create a healthier Indonesia.
And now we will proceed to the next agenda. Ladies and gentlemen, distinguished guests, before we proceed further, let us pray together for today's event. I would like to invite Mr. Ujang Nurjaman, SKM MKes, to lead our prayers. To Mr. Ujang Nurjaman, SKM MKes, the time is yours.
Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning and greetings to all. Let's thank to God this morning we can meet together in international conference by team building global health resilience through professional collaboration, sustainable solution in types 2, diabetes mellitus, care and community empowerment here. Before this conference start, let's pray fervently for each religion. Allow me to guide you all, pray according to guidance of Islam. A'udzubillahi minasyaitonirrajim. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Hamda syakirin, hamda na'imin. Hamda yuafi ni'amahu wa yakafi mazidah. Ya Rabbana lakal hamdu kama yang bagi li jalali wajhikal karim wa azimi sultanik. Allahumma sholli ala sayyidina Muhammadin salatan tunjina biha min jamil ahwali wal afat wa taqdi lana biha jamil hajat wa tutahhiruna biha min jami'i sayyi'at wa tarfa'una biha indaka ala darajat wa tuballighuna biha aqsal ghayat min jami'il khairat fil hayati wa ba'dal mamat. Allahumma tawil umurana wa sahih ajsadana wa nawwir qulubana wa thabbit imanana wa ahsin a'malana wa wasi' arzaqana wa ilal khairi qarribna wa anis syari abidna wa qadhi hawaijana fid dini wa dunya wal akhirah innaka ala kulli syai'in qadir. Ya Allah, there are no words and feelings that we deserve to convey to you this morning, except our gratitude for all blessing and guidance that you have given us so that we can attend together in this international conference. Ya Rahman, please make this conference getting your blessing, mercy, and guidance. Ya Rahim, please grant us good innovation in every task execution. Give us heart, strength, and ability, so that we are able to carry out duties and responsibilities for the good and benefit for our community, nation, and country. Ya Hafid, Ya Majid, unite for heart, our step, and grow a sincere of brotherhood. Keep our souls in purity and decorate our morals and will exemplary. Only to you we worship, ask forgiveness and help. Ya Allah, please accept our prayer and supplication. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Subhana rabbika rabbil izzati amma yasifun. Wassalamun alal mursalin walhamdulillahi rabbil alamin. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Mr. Ujang. Ladies and gentlemen, before progressing our agenda, let me read again our event rule as follows. Our event will be held for 2 days, 22nd and 23rd October 2025. The first agenda will consist of the main session in the morning, followed by the plenary session. The second agenda will consist of expert session and conference. Participants can join this international conference by using Zoom Cloud Meeting platform for the first 500 participants, and for the rest participants can access it through our YouTube channel, Media Poltekkes Bandung. Participants are required to rename the Zoom account into country_real name during this virtual meeting. For example, Indonesia_Surmita. In order to get the certificate, participants should attend the first and the second days of the conference. Participants should fill in the attendance, evaluation form, and post-test in Pelataran Sehat. Participants are requested to deactivate the microphone during the session. Thank you for your attention. Ladies and gentlemen, for the next agenda, there will be a photo session. For the photo session, I would like to invite all the participants in Zoom printing platform to open your camera. We have several slides at this time, and I will begin with the first slide and continuing until we are reaching our last slide. Ladies and gentlemen, please keep your smile until the end of the slide, because we don't know where your screen is. Okay, let's start the photo session. Thank you for joining our photo session. Um, we, we- Ladies and gentlemen, we are now continuing our meeting to the next agenda. To know more about Poltekkes Kemenkes Bandung, we're glad to inform you about video profile. Please welcome video profile of Poltekkes Kemenkes Bandung.
Politeknik Kesehatan Kementerian Kesehatan Bandung, or Poltekkes Kemenkes Bandung, is a state vocational higher education institution under the Ministry of Health of the Republic of Indonesia. As a strategic center for health education, Poltekkes Kemenkes Bandung is dedicated to producing professional, ethical, and globally competitive healthcare professionals. Poltekkes Kemenkes Bandung is located at Jalan Pajajaran number 56, Bandung City, West Java. Bandung is known as a cool and comfortable educational city. Our vision is to be a leading health polytechnic, excelling in applied technology, character development, and global competitiveness. This vision guides our every step as we grow and contribute to healthcare, both nationally and internationally. To achieve this vision, Poltekkes Kemenkes Bandung is committed to 7 core missions. First, provide high-quality education aligned with global orientation in applied health science and technology, producing graduates of strong character. Second, conduct innovative applied technology-based research that leverages local resources and wisdom while empowering communities. Third, implement innovative community service initiatives that have a broad impact using research to strengthen quality education. Fourth, foster partnerships with national and international stakeholders for mutual progress. Fifth, develop new educational programs to meet the evolving demands of health science and technology. Sixth, cultivate an integrated and ethical workforce to ensure good and clean governance, operating with transparency and accountability as a public service institution. 7. Lead health transformation by establishing a center of excellence for diabetes mellitus education, integrated into our core academic activities of teaching, research, and community service. Poltekkes Kemenkes Bandung has the following human resources. Poltekkes Kemenkes Bandung offers a variety of academic programs designed to train competent healthcare professionals. Our departments include the Department of Nursing, the Diploma of Nursing program in Bogor, Department of Midwifery, the Diploma of Midwifery program in Bogor, the Diploma of Midwifery program in Karawang, the Department of Environmental Health, the Department of Pharmacy, the Department of Nutrition, the Department of Dental Health, the Department of Medical Laboratory Technology, and Department of Health Promotion. Those campuses are spread across several cities. Campus A is in Bandung. Campus B is in Cimahi. Campus C is in Karawang. And Campus D is in Bogor. Poltekkes Bandung achieved the highest 100% competency test pass rate in 2024 at the national level. Students and lecturers at Poltekkes Bandung not only excel in academics, but also actively excel in various activities, including research, student organizations, community service, and local, national, and international competitions. The numerous awards they have won prove their strong competitive spirit and ability to bring recognition to our institution. To support a comfortable and innovative learning environment, Poltekkes Bandung provides various facilities, including interactive classrooms, modern laboratories, a library, a network of partner hospitals, sports facilities, and student dormitories. These resources are designed to help students grow holistically.
As the director of Poltekkes Bandung, we remain firmly committed to upholding educational quality, driving innovation, and making tangible contributions to the advancement of national health. Through education, research, and community engagement, we are confident that Poltekkes Bandung will consistently produce generations of healthcare professionals who demonstrate integrity, excellence, and competitiveness at the global level.
With a clear vision and focused mission, Poltekkes Bandung is ready to produce professional, ethical, and highly dedicated healthcare professionals. Together, let's create a healthier Indonesia.
Ladies and gentlemen, now we will glad to hear the keynote speech, Building Global Health Resilience Through Interprofessional Collaboration. Keynote speech will be delivered by acting Building Global Health Resilience Through Interprofessional Collaboration by Dr. Yudi Pramono Mars. Ladies and gentlemen, please welcome Dr. Yudi Pramono Mars to give the keynote speech and opening our conference.
Okay, thank you. Good morning, everybody.
Good morning.
Good morning.
Mr.
Good
Yudi.
morning. Good morning. Good morning. Good morning. Good morning.
Bu Pramita, bisa kita mulai. Suaranya
sudah, Pak.
bergema.
Sudah. Silakan Pak Yudi.
Silakan Pak Yudi.
Suaranya bergema.
Ya, silakan Pak.
Oke, makasih. I'm sorry. Good morning, everybody. Maybe I'm speaking bahasa ya. Ini minta wakili Bu Dirjen.
Ya.
Jadi,
Ya.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Selamat pagi, salam sejahtera untuk kita semua. Swastiastu, namo buddhaya, salam kebajikan, salam sehat untuk kita semua. Bapak Ibu sekalian yang kami hormati, bahwa kalau kita lihat beban diabetes ini terus meningkat di seluruh dunia. Dari Federasi Diabetes Internasional memperkirakan kurang lebih ada 11% dari populasi di seluruh dunia hidup dengan diabetes mellitus. Dan di Indonesia sendiri ada sekitar 20 juta orang terkena diabetes. Angka ini juga diperkirakan akan terus meningkat, lipat ganda pada tahun 2045 apabila kita tidak lakukan penanggulangan dari sekarang. Selain itu juga kalau kita lihat masih banyak kasus yang belum terdiagnosis, terutama di daerah pedesaan yang menyebabkan adanya komplikasi yang memerlukan penanganan dengan beban biaya kesehatan yang tinggi. Fakta ini menunjukkan dengan jelas bahwa untuk diabetes mellitus tipe 2 bukan hanya masalah klinis, tetapi juga tantangan sistemik dan komunitas. Hal ini juga memerlukan kolaborasi antar profesi dan pemberdayaan komunitas. Tidak ada profesi atau sektor tunggal yang dapat menangani kompleksitas perawatan untuk diabetes tipe 2 secara sendirian. Diperlukan kolaborasi antara dokter, perawat, apoteker, ahli gizi, dan kesehatan masyarakat, kita berkelanjutan dan berpusat pada pasien. Mulai dari pencegahan dan screening hingga pengobatan dan ketika tenaga kesehatan bekerja sama dan melibatkan pasien sebagai mitra, maka hasilnya akan meningkat secara signifikan. Oleh karena itu, kita perlu memastikan bahwa tenaga kesehatan memiliki keterampilan dan kemampuan kerja tim untuk mengelola diabetes mellitus ini secara efektif. Bapak Ibu sekalian yang kami hormati, konfederasi ini merupakan platform berharga untuk saling berbagi penelitian, inovasi, dan best practice. Mulai dari intervensi, dari keperawatan yang berpusat pada pasien, hingga transformasi digital dan kolaborasi antara penelitian dan kebijakan. Mari kita manfaatkan kesempatan ini tidak hanya untuk berdiskusi, tetapi juga untuk mengubah atau membuat ide menjadi langkah konkret, membangun kemitraan interprofesional, serta mengembangkan solusi yang benar-benar memberdayakan komunitas dan memperkuat sistem kesehatan kita. Bersama-sama mari kita berkomitmen untuk membangun ketahanan kesehatan global, karena dengan sistem yang tangguh, komunitas yang diberdayakan, dan kolaborasi antar profesi adalah kunci untuk mengalahkan diabetes dan penyakit tidak menular lainnya. Bapak Ibu sekalian yang kami banggakan, sebagai penutup, saya ingin mengucapkan terima kasih kepada Poltekkes Bandung atas penyelenggaraan acara ini, para pembicara yang menginspirasi, dan semua peserta yang turut berpartisipasi. Dan saya berharap kita dapat memperoleh wawasan dan koneksi dari konferensi ini dan menjadikan perubahan nyata dan berkelanjutan berkesinambungan. Bersama-sama kita dapat membentuk masa depan di mana setiap orang memiliki kesempatan untuk hidup lebih sehat dan lebih bermakna. Terima kasih, selamat mengikuti konferensi. Semoga kita semua selalu diberikan kesehatan dan kesejahteraan.
Amin.
Wassalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sehat, Om Santi, 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 Om. Salam sehat untuk Indonesia.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
Terima
wabarakatuh.
kasih Pak Yudi.
Sukses, Bu.
Terima
Ya,
kasih Pak.
amin. Terima
Terima kasih Pak
kasih.
Yudi.
Thank you, Dr. Yudi Pramono Mars, for the warm keynote speech. Ladies and gentlemen, we have arrived at the main session of this international conference. The presentation of material by awesome speakers, as well as discussion session, which will be guided by the moderator. The morning session will be moderated by Mr. Johannes Wilhelm Saleki, Master of Science. Mr. Johannes Wilhelm, Master of Science, currently work as lecturer in Nutrition Department, Bandung Health Polytechnic. Without further ado, please welcome our extraordinary moderator in the first session, Mr. Johannes Wilhelm Saleki, Master of Science. Time is yours.
Okay, thank you very much, MC, for the opportunity. Assalamualaikum warahmatullahi wabarakatuh. Shalom. Good morning to all distinguished guests, speakers, and participants joining us from around the world. On behalf of the organizing committee, it is a great pleasure for me to be with you today in the 8th International Conference on Interprofessional Health Collaboration and Community Empowerment 2025 with the theme Building Global Health Resilience Through Interprofessional Collaboration, Sustainable Solutions in Type 2 Diabetes Mellitus Care and Community Empowerment. Ladies and gentlemen, my name is Johannes Wilhelm Saleki, and I will be your moderator for this morning's session. We are truly honored to have such a diverse group of experts, researchers, practitioners, and students gathered here today, all united by a shared commitment to advancing knowledge and fostering collaboration across borders. In this morning session, we will have distinguished speakers who will share their valuable expertise and perspectives. Before we begin, I would like to extend our gratitude to our organizing team and partner institutions for making this event possible. Here's a brief outline for our morning session. The first topic of the session, entitled Policy and Research Collaboration in NCDs for Sustainable Health Access, which will be delivered by Dr. Hadiza binti Haji Abdul Mumin from University Brunei Darussalam. And the second topic would be entitled Interprofessional Nutritional Strategies to Enhance Metabolic Resilience in Type 2 Diabetes Mellitus Care, which will be delivered by Dr. Judiono MPS from Polkesban Bandung, Indonesia. And the third topic would be about digital transformation in primary diabetes care opportunities and risks, which will be delivered by Dr. Anjanit De Leon from Centro Escolar University, Philippines. Each speaker will have 45 minutes to deliver their presentation. After all presentations, we will have the Q&A session, so please feel free to type your questions in the chat box, or for those who are joining from YouTube, you can also submit your questions through its chat box. Once again, welcome to this morning session. So let us make this as an inspiring and insightful discussion. Ladies and gentlemen, distinguished guests and speakers and participants, before we proceed to the first speaker of the session, I would like to briefly introduce you to our first speaker. So to the operator, please bring the CV on the screen, and I would like to highlight some of the profile of our first speaker. So we are going to have Dr. Hadiza. As a distinguished leader in nursing, midwifery, and health sciences for over 20 years of experience, advancing healthcare education, research, and interprofessional collaboration. Her academic and professional journey reflects deep commitment to building global health resilience through teamwork, community engagement, and evidence-based practice. At University of Brunei Darussalam, she has led numerous initiatives integrating interprofessional education across nursing, medicine, midwifery, and public health disciplines, strengthening collaborative competencies essential for sustainable healthcare delivery. Dr. Hadiza's research portfolio demonstrates her leadership in multidisciplinary and international collaborations. Her study on self-care, aging, physical activity, and mental health resilience have influenced health policy and practice in Southeast Asia. She also leads and mentors interprofessional team of nurses, midwives, physicians, psychologists, public health experts in projecting addressing the psychosocial and behavioral determinants of health and chronic disease management. Her global recognition includes the Australian Award Fellowship 2025, and US Research Fellowship, and multiple international awards for teaching and research excellence. Beyond academia, Dr. Hadiza has contributed significantly to community empowerment programs, particularly in maternal and child health, aging, and chronic disease prevention. Therefore, we strongly believe that her tireless efforts embody the conference vision. So, Dr. Hadiza, are you with us right now?
Hello.
Hello, good morning, Doctor.
Assalamualaikum. Good morning.
Waalaikumsalam.
Yeah.
How are you,
Good
Doctor?
morning, Miss.
Alhamdulillah, thank you so much for inviting me to the conference. I'm very honored. I think this is the second time, right? I'm delivering the session with Polkesban Bandung.
Yeah.
Yeah. I've invited once by the sample Polkes, I think. But thank you so much again for inviting me. Yep.
Okay, thank you very much, Doctor, for you are ready and all set. So, ladies and gentlemen, without any more delay, please joining me in welcoming our first speaker, Dr. Hadijah binti Haji Abdul Momin, who will present about policy and research collaboration in NCDs for sustainable health access. Dr. Hadijah, the screen is yours.
Yep. Thank you. Assalamualaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. Are you going to share the slide, or am I going to share the slide? Is it from me? No, it's not from me. It says
Okay.
someone else is sharing. Yeah. So we're waiting for the slide, yeah?
Yeah, the committee, maybe you can display the slide.
Okay. Bismillahirrahmanirrahim. Assalamualaikum again, everyone. Thank you so much for coming, and thank you for inviting me to the conference. We will talk today about policy and research collaboration in non-communicable diseases for sustainable health access. So I will be talking about the policy and research side of it. So let's move on to our next slide. So in talking about sustainability, we are going to look into the global and national policy landscape for the non-communicable diseases. We're looking into what are the global and national policies available, how are the current situations, and how the policy and research collaboration enhances sustainable health access, and as well as practical framework. An example for, I will give you some example, one or two examples on how we can be collaborating in terms of research and policy, and as well as how are we going to localize the policy impact, localize the research for the policy impact and sustainability. Next one, please. So the global burden of non-communicable diseases is not new. Okay, I think since the beginning of time, when we designed the curriculum for the healthcare profession, NCDs has been the main point, the central in the curriculum. Okay. Aside from that, of course, we have communicable diseases, which actually challenge us during the COVID-19. Okay. And the NCD account for 70% of global death, which is rising in our low and middle income countries. So the most common diseases, everyone know about it. It's heart disease, cancer, diabetes, chronic respiratory diseases. So of course, it have profound impacts, okay, on our health, on our social health, and also on the economic. Because if we are going to be admitted in the hospital for a long time, then it will have economic impact on our country, okay, because the country have to spend on us. And socially, if we are not healthy, we can't be outside and mingle around with people surrounding us. Okay, so more again, if it is physical health, especially with diabetes, there will be a lot of complication, hypertension. Also, we have a lot of complication, and it will make our health complicated the way through. Next one. So understanding sustainable health access is very important. As you can see from the diagram below, it is not about equality, it is about equity. Okay, if you treat everyone equally, then that's mean you are depriving them from the optimal care that the person should be having or should be getting. Okay, but if we treat people with equity, it is likely that we are giving equal care, optimal care, and quality care for all the clients or all the patients under our care. So equitable means that we have continuous access to essential health services. So the key dimensions is affordability. We can afford it, we can pay for it. Availability, it is available all the time. Accessible, people can reach it no matter we are in the remote area or the rural area, we can access it. And quality, quality is the minimum standard possible. Okay, and this sustainable health access concept is linked to SDG number 3 and universal healthcare coverage, okay, by the World Health Organization. Is SDG number 3? Who knows what's SDG number 3? Let's go on the next slide. This is our sustainable development goal. So SDG number 3 is good health and well-being. Next slide. So in the next slide, you can see the details. Okay, perincian ya, perincian mengenai dengan good health and well-being. So in this SDG number 3, you have more on health, on maternal health, on infant care. So NCD is also important among pregnant women, especially if it is related to diabetes, hypertension. It can complicate their pregnancy, yeah. And also, if you look into the infant, also, if they don't have a normal physiological changes after newborn, after they are newly born, then they will have heart diseases, such as, if the foramen ovale is not closed, if the ductus arteriosus are still pattern, yeah. So these are some of the example of the non-communicable diseases and sustainable health access. Next one. So we're moving on to the universal health care for all. So according to the World Health Organization, they said that universal health care should be attainable to all population in the world for the minimum standard of health. Okay, so health for all and the sustainable development goal are very important. So meaning that whether you shouldn't be having problem with money, you shouldn't be having problem with poverty, and you shouldn't be having problem with being homeless. Everyone actually should be have accessibility to universal healthcare. So as you can see there, it resembles the umbrella. So from baby to old age, everyone should be actually accessible, yeah, to the universal healthcare. Next one. Okay, why policy research collaboration matters? Okay, so when we talk about policy and research collaboration, what does it mean? Why does it matters? So it means that when we are talking about research, it can influence policy. Okay, research, we have evidence. Evidence inform policy. But as researcher, we are not policy maker. Okay, so there are policy maker who are researcher, but researcher does not necessarily mean they are policy maker. So what it means here is policy usually it sets priorities, but research provide the evidence, as I mentioned earlier. Okay, so if we collaborate in terms of nationally among all the ministries, among all the departments, it will promote evidence-based decision making. Okay, the decision is not only by ourselves, but also by the people who are working with us from the different areas. Okay, so this is national collaboration. But if we move regional, then it could be the ASEAN region. And if we move international, then we can be, across the globe, including the European countries, English-speaking countries, and also Latin America and also America. Okay, so why policy and research collaboration matters is because it prevents fragmented responses and enhances innovation. Okay, the findings from Brunei might be similar to Indonesia. Okay, if we say, okay, this is from Indonesia, it will inform the practice of Indonesia. However, if you include Brunei in, Brunei can be learning from Indonesia. So similarly, Indonesia can also be learning from Brunei. So as such, we are exchanging our ideas and sharing our policy. Okay. Next one. So global and regional policy framework, we have one by the Pan America Health Organization as well as the World Health Organization. We have the non-communicable disease roadmap. Yeah, non-communicable disease roadmap. This was introduced earlier in 2023, and it should expire it is an extended version of the initial plan on the prevention and control of non-communicable diseases, which was introduced in 2013. And it should be until 2030, the outcome. However, in 2023, the World Health Organization introduced the roadmap, how we are going to reach the prevention and the control of non-communicable diseases. Let's move on to the next slide. So in the next slide, you can see the non-communicable disease global monitoring framework, okay, GMF. So as you can see there, they have target on the heart disease, physical activity, sodium intake or the salt intake, and so forth. Okay, so these are the global monitoring of things. They have 25 indicators at least across the these cardiovascular disease, cancer, diabetes, or chronic respiratory diseases. They have 25 indicators at least. So in the non-communicable diseases global monitoring framework, we actually looking into reducing or halting whatever non-communicable diseases that occurs in our country. Okay, that is the aim of World Health Organization. Next one. The World Health Organization also proposed the global surveillance and monitoring framework in such a way that they look into the impact indicator, the performance indicator, the progress indicator, and as well as who play which role and all the documents available for us to refer to so that we can monitor and do the global surveillance appropriately. Next one. So in terms of public health surveillance, in terms of non-communicable diseases, the World Health Organization, in collaboration with the Pan America Health Organization and as well as Center for Diseases Control in America, they believe that there should be ongoing systematic structure on the planning, implementation, and evaluation of public health practice related to non-communicable diseases. So they said that it should be conducted regularly, the surveillance, it should be systematic, it should be at the minimal standard, it should be conducted not too long, not too short, but in a timely manner, it should be sustainable, and it should evaluate policies, programs, and interventions that is directed towards minimizing non-communicable diseases occurrence. Okay. And also the information for decision making so that when we have the data, we can inform the policy. Okay. Next one. So another one is our United Nations Political Declaration on Non-Communicable Diseases. So this was introduced in 2018, and as you can see, the aim and objectives are similar to our global document. Okay, next one. So in the next one, this is the example of our regional policy framework. Okay, we have the ASEAN post 2015 Health Development Agenda, and it should expire this year, 2025. Okay, so in chapter 2, they talk about non-communicable diseases through the promotion of healthy lifestyle. So this document is accessible. You can access it for free online. Okay, next one. In the next one is our national principle. So we have international policy, the World Health Organization, who influence our services, who influence our thinking, who influence the policy around our region. Okay, World Health Organization is the main key player. Then we have regional. We also have the ASEAN community, the Association of Southeast Asian Nation, authority who actually produce a book on which is related to non-communicable diseases. And we also have in our country, our local policy. Okay, so in the local policy, we are looking into the whole of society and whole of government approach. Okay, we are looking into how we can work together. So meaning Ministry of Health can be working in isolation, right? So Ministry of Health should be working with Ministry of Education. Probably Ministry of Education can help with integrating non-communicable diseases education from younger, from a younger age, from the primary school. And the Ministry of Education can collaborate with Ministry of Health in terms of promoting healthy lifestyle among youth. Yeah. And aside from that, the Ministry of Sports can also conduct a few activities that can promote the health of the people in Indonesia or in Brunei. Yeah. So this is what we call as whole of society and whole of government approach. So one ministry cannot be working in isolation of each other. So each ministry should be working together to produce maximum impact, yeah, towards prevention of non-communicable diseases. Next one. But question is, what are the context and the gaps? So in terms of when we have research conducted on the non-communicable diseases, we have a research. I believe Indonesia. I think Indonesia has a lot of information. I also encounter into various global diseases burdens from Indonesia, your publication from Indonesia. And the strategies emphasize prevention and control. Okay. However, in each country, especially in low middle income country and some higher and middle income countries, we have gaps. We have limited data, limited funding, and limited linkage of the research finding into policy. What happened is when we conduct research, we publish the evidence, stay at the publication and stay in the journal, and it does not come out and it does not reach the Ministry of Health in terms of policymaker. Okay, so sometimes we are doing research in isolation, okay, in silo. We are doing it in silo. So what happened is our government doesn't know our findings. So even if they know about our findings, they might not know how to use the data. Okay, because sometimes as academician, as researcher, we use jargons like, we do regression analysis. We have significant power of p less than or equal to 0.05. All those jargons, research jargons, all those research terms. So what happened is the Ministry of Health or the other ministries also who are related or who are interested to use our data, they can't be using our data because they don't understand what we are talking about. So there should be actually an opportunity to integrate the research into the policy. Okay, we need to have think tank, people who can think of being a researcher and also being influential in policy making. So we need to have rapid evidence platform, not only in terms of in academic journal, but also in registry. Okay, in Indonesia and in Brunei. For example, we have diabetes registry, we have hypertension research registry, we have cancer research registry. So we know that people are doing things that we want to change policy or things that we want to help with improving our policy. Okay, next one. So on terms of the research dimension, what we are talking about is we have epidemiology, we have statistics, okay, but we want to implement it to become policy. And we also need to contextualize the data and translate it into practice, okay? Research, we do it, fantastic result, beautiful result, but how do we inform policymakers so that they can improve the policy and improve the care of the people in Indonesia? Okay, so that's mean we need to translate our research into knowledge and into practice. Okay, so policy uptake requires dialogue and trust. So there should be a dialogue between the Ministry of Health, Ministry of Sports, for example, Ministry of Education, and all other ministries with the academic researcher institution. Okay, next one. So how do we ensure that we have a collaboration? So we need to have a shared goal and accountability. We need to have joint agenda setting, meaning that researcher with her or his own thinking, and then Ministry of Health with what they want in the Ministry of Health. It should be Ministry of Health sitting down with the academic researcher and mention to the academic researcher that we want changes, but we want to find out what happened in our ministry. Okay, what happened in our hospital. And then the researcher said, okay, conduct research, and they know that this is happening, and how can we use this research finding to inform your policy so that we can change the care that we are giving in Indonesia. Okay, so continuous communication and monitoring and adaptive learning is very important. Next one. Next slide. So this is example of diabetes, as I mentioned earlier. So if we have research about diabetes, then we need to have National Diabetes Registry. Okay, this finding can help in policy reform and improve the screening and treatment access. And then, for example, we have early detection of diabetes. We cutting costs on certain things that need to be cut. For example, if in the policy that we have regular appointment and also regular education, so probably we can cut costs in terms of people who are suffering complication during diabetes can be reduced. Okay, and we can align the capacity and stakeholder ownership. Yeah, meaning that if we involve our stakeholder, whoever the stakeholder are, not only we can make policy, but the policy can be belong to everyone. Okay, people can have a sense of ownership. They feel that, okay, the policy is made by us because we are involved in it. Okay, next. So these are how we strengthen the evidence. As I mentioned earlier, we should institutionalize the evidence. We should put it in the registry. Develop national and regional non-communicable diseases observatories or center, and invest in implementation research and data sharing. Okay, I understand that in Indonesia you already have WHO collaborating center. So WHO collaborating center is a kind of observatories that can take charge of if you have the non-communicable diseases issues that you wanted to tackle. So WHO collaboration center in Indonesia can have an active role in that. Okay, can we have the next one? Next slide. So these are some of the challenges. Okay, we have fragmented system, meaning that we don't have continuity. People are doing their own things. Researchers do their own thing from the academic institution. Ministry of Health do their own things. Ministry of Sports do their own things. Ministry of Education do their own things. And then we have short-term funding. We don't share our data, and it limits our capacity. Next. So it should be on the political side. It should be coming from them, from the leadership, yeah, from the leadership of the president, the minister, even your directors, yeah, director general. They should be supportive of policy changes. They should be supportive of research. Sometimes we are so afraid to do research because we are so afraid that it will produce negative results. Okay, but negative result is good because we can improve our practice if we find out that we have negative feedback. Okay, so it needs long-term commitment from people from various position, from the leadership position, from the head of nursing, head of midwifery, head of healthcare. Yeah, we need to have accessible to digital transformation, and as well as regional partnership with our partner countries, Brunei, for example, ASEAN country, Brunei, Indonesia, Philippines, Thailand, for example. Okay, next one. And we also need to empower the community and ask them to take ownership. Yeah, if we involve the community, we engage them as our partner. We can address the social determinants of health easily, okay? And we can appreciate their culture, as well as if we already engage them, we know what are the social determinants, then we understand their culture, then we can give the care or the policy, we can, give the care according to the policy, which is developed to address the equity. Next one. So this is the implementation through partnership that we can do. As I mentioned earlier, it should be from various ministries, for example, health, education, sports, and finance. It should be not only from academic institution, but also we involve non-government organization and private sector partnership. We also need to have joint training and research grant. and we need to be accountable in our governance. Okay, means that don't be afraid. We have to do the research. If you are embarrassed to report the findings to the world, then you can, you can share the finding as a white paper, okay, as a policy paper. No need everything for publication. Okay, next one. So the way forward that I see it is we need to strengthen our NCD research capacity. I know that Indonesia has been doing great job. You have been doing a lot of collaboration with other people from other countries, creating platform for evidence-based policy integration so that we do not repeat. Sometimes what happen is if we do not have registry, if we do not have evidence policy platform, we tend to repeat the same research all over and over again. Okay, so in such a way, if we have those research capacity, if we have the platform, then we can align the global and national health priorities, and then we can institutionalize collaboration through the academic institution, through the healthcare institution, through the non-government private sector in terms of healthcare provider, for example, and so forth. Next one. So in conclusion, non-communicable diseases control demand coordinated, sustained and evidence-based policy, as I mentioned earlier. It needs collaboration. It also needs shares vision and also shared evidence so that we can have sustainable health access. Okay. If we do not collaborate with each other, if we can share our result, then what happen is we can sustain the health access to everyone. Next one. I would like to thank you very much again. Jazakallahu khairan kathira. I will see you afterwards. Thank you so much.
Thank you very much, Dr. Hadiza, for the enlightening presentation. Ladies and gentlemen, as we have witnessed together the presentation from Dr. Hadiza, who explained to us about the importance of the interprofessional collaboration. So I remember that she said one department or ministry cannot work in isolation. Therefore, we should promote interprofessional collaboration from the government sectors to the private sectors, from the researchers, academias to the policymakers. And the researchers need to integrate or advocate their evidence-based findings that can be used as the consideration in policymaking. Of course, it should be translated into more practical recommendations. Such an interesting ideas, Dr. Hadija. Thank you very much. And we would like to ask you to please remain with us, Doctor, until we enter our Q&A session at the end of the third topic. Thank you very much, Dr. Hadija. Now, ladies and gentlemen, we are proceeding to the second speaker of this session. We will be having Dr. Judiono, MPS, who will be presenting about interprofessional nutritional strategies to enhance metabolic resilience in type 2 diabetes care. Mr. Judiono, are you already here with us?
Yes, I'm okay.
Okay, thank you very much, Doctor.
Yes.
So, ladies and gentlemen, before I hand this opportunity to Dr. Judiono, please allow me to explain briefly about the background of Dr. Judiono. So, the operator, please display the CV of Dr. Judiono. So, Dr. Judiono is a highly respected nutrition scientist and community health expert with a distinguished record in the fields of functional foods, probiotics, biomedical nutrition, and degenerative disease research. His pioneering studies on kefir-based probiotics and macronutrient-enriched diet have significantly contributed to advancing sustainable dietary intervention for type 2 diabetes mellitus. With a career spanning academic leadership, research, and community development, Dr. Judiono embodies the principle of interprofessional collaboration in building global health resilience. Dr. Judiono also has the extensive research explores the biomolecular mechanism of food bioactives and probiotics in improving metabolic health. His groundbreaking works include the role of plant kefir, probiotics on glycemic, antioxidant, and immune status in diabetes mellitus patients, spirulina kefir probiotic innovation for improving glycemic control, antioxidant capacity, and post-GLUT4 receptor response in type 2 diabetes. And also, this project illustrates sustainable food-based solution that support community empowerment and chronic disease prevention, aligning seamlessly with the conference vision. Dr. Judiono also won some grant from Danan Institute of Indonesia, and also he is the member of Indonesian Nutrition Association, International Probiotic Society, and International Functional Food Bioactives Network. So through his scientist leadership, Dr. Judiono promotes a multidisciplinary and interprofessional approach to nutrition research. Therefore, we believe that by integrating academic research, community engagement, and applied nutrition innovation, Dr. Judiono's career and also experiences can be a great benefit for us today to witness about the topic they're going to be delivered by Dr. Judiono. So if everything is set, Dr. Judiono, you can start the presentation. The screen is yours.
Thank you very much, Mr. Willis. I will take over to deliver my presentation. Good morning, ladies and gentlemen.
Good morning.
Respected.
Morning, sir.
Hello.
Yeah.
Can you hear my voice?
Yeah,
Yes,
it's
we can
clear.
hear you, Mr.
You can continue.
Are you here?
Yes, sir. You're
Yeah.
clear.
Good morning. Selamat pagi, magandang umaga sa inyong lahat. Respected colleagues and participant, researcher, lecturer, and so also student. Today, I will present an integrative perspective on interprofessional nutritional strategies designed to enhance metabolic resiliency in the type 2 diabetes mellitus care, with growing concern in Indonesia and globally. On this session, I would like to present 11 core topic in this session. The first, I would like talking about the background. Secondly, is concept metabolic resiliency. And the third, interprofessional collaboration framework. 5 nutritional strategies for type 2 diabetes. And 6, enhance metabolic resiliency. 7, evidence-based interpretation. And 8, case example and implementation. 9, challenges interpersonal practice. And finally, recommendation for future practice and conclusion. Next, slide 2. Yeah, the type 2 diabetes continue to increase worldwide. This trend strongly linked to unhealthy diet and also sedentary lifestyle, and also poor metabolic adaptation. Current diabetes management still focus on heavily on pharmacology treatment, while nutrition-based and collaborative preventive approach remain underutilized. This study advocate for an integrative interpersonal framework linking nutrition, pharmacy, nursing, community empowerment, and also health promotion. Next slide. The concept metabolic resiliency. Metabolic resiliency is the body ability to maintain metabolic stability despite stressors such as diet, inflammation, or insulin resistance. Nutrition plays a central role in strengthening this resiliency, and it can be only be effective achieved through teamwork between dietitian, pharmacists, nurses, and physician. Next slide. Interpersonal collaboration framework. This model integrated all professional role into a share of care pathway. Nutritionists design personalized dietary plan. Pharmacists monitor drug and nutrition interaction. Nurses provide behavior support, and health promotion ensure patient engagement. Through this IPA-based diabetes care pathway, we can achieve better glycemic control, education, and also adherence. Next slide. Nutritional strategies for the type 2 diabetes. Nutritional management focuses on the balanced micronutrient, which consists of 50 till 60% carbohydrate, 15 to 20% consists of protein, and 20 till 35% was as fat. It is just for individual need. We emphasize functional food with high in fiber, low in glycemic index, and also local resources such as legume, wheat, and traditional fermented food. Personalized plan must reflect it, culture and also socio-economic context. Next slide. This is a glycemic index. We can see that there is in the diet, it should be fulfilled to reduce blood glucose in the patient, because when we eat or we mean it with the glycemic index treatment, we can reduce about blood glucose in the patient. Next. Yeah. Nutritional strategies enhancing metabolic resiliency. Beyond of diet composition, we highlight anti-inflammatory and antioxidant food. We know that in the diabetes, usually there is change of biomolecular metabolism. There is will impact on the ROS, reactive oxygen species, and also free radical. So that way, during 2 minutes the diet composition, we highlight with anti-inflammatory and antioxidant rich food, and also omega-3 diet beside a polyphenol and plant-based option. Equality important is also chrononutrition. That is the timing of meal and portion to control blood glucose and other consequences that affect for the high blood glucose in the body. When integrated with exercise and medication therapy, this strategy collectively enhance metabolic resiliency and also reduce insulin resistance. Based on my experience, who research in the diabetic patient, we know that many by diet and also exercise beside add with the food functional, it can reduce very good achievement. Next slide. Secondly, we also studied in the 2023 that is demonstrate community-based nutrition education, improve nutrition dense and also in dense intake, reduce parameter of HbA1c, and also increase self efficacy among T2DM patient. Such evidence confirm that interpersonal approach combining nutrition, pharmacology, and also education yield measurable metabolic benefit. And also my experience who conducted the research and also community services in the community school of student senior high school in some part of Bandung, West Bandung, this sub-district. We found that when we evaluate that number of adolescent is also like syndrome metabolic increases. Then we try to make integrated program who consists of nutritionist and also some teacher from school and also other health human resources such as from center of from center of health. We saw that there is a trend, there is a reduce from the case of syndrome metabolic. Next, the evidence-based integration, case an example. In our field application, dietitian and pharmacist jointly monitoring patient at the community clinic. The pharmacist ensure safe medication food combining, while the clinical dietitian provided toilet meal plan and also other tracking. This teamwork significantly improve patient compliance and also metabolic outcome. Next slide. The challenges in the interpersonal practice that we can show from the applied of the EPA and EPC. There is several barriers remain we found during we implemented the interpersonal practice, such as limited communication channel among healthcare team. That we saw that because not all the team ready to give some information rely for the program. Next, low nutrition literacy among non-diabetic staff and resource constraint for community-based follow-up. when we propose integrating interpersonal education (IPA) module into health curricula to strengthen collaboration skill in early is very better than without any others program. So that way, during the session of the final study, usually our student there is some program that there is implemented community services like KKN in Indonesia. There is consists of several team such as dietitian, nutritionist, health sanitarian, and also pharmacists, nurses, and dental nurses, and also pharmacists in the community. This is some part of why we try to prepare about the next future for our college student, and also teamwork in the health the Polytechnic Bandung. Next, the recommendation that for the future to implement it, the interpersonal collaboration and also interpersonal practice, we recommend that embedded interpersonal nutrition strategies into national diabetes policy is very, very important, because unless it is very useful that we don't have any policy that in the national. Strengthening also, we also in the Center of Health or Puskesmas IPA model, and the development telehealth platform that Dr. Hadiza said that mentioned in the earlier, that nutrition medical consultation also. This is very important. Promoting multi-center collaborative Asian across Asian country is really need for the future. I agree with Prof. Hadiza from the Brunei that promoting multi-center collaborative research across the season is needed for the next our program. So, we hope our government will support finance and also from foreign funding agencies. Next, finally, we can say that nutrition center interpersonal collaboration is not optional. It is very, very essential. By working together across a discipline, we are not only treat disease, but also nourish metabolic relationship and also build sustainable health system. Finally, together, we nourish the relationship through collaboration, and we said that it will improve our global and national health community. Thank you very much for the time. I hope we can share, we can discuss with our material. Thank you very much, committee. Back to moderator. Thank you.
Thank you very much, Dr. Judiono, for the insightful presentation. And we are experiencing your material that highlighting about interprofessional collaboration in managing diabetes. Also some interesting idea that you stated that we have to recommend to be at the national level for the interprofessional collaboration. Maybe we will have the discussion further after the session. So we would like to ask for Dr. Juliana to please remain here with us as we will enter the Q&A session after the third speaker. Thank you very much, Dr. Juliano.
Thank you, Pak Willy.
All right, ladies and gentlemen, now we are moving to the third speaker. But before that, I would like to welcome first our third speaker, Dr. Anjani De Leon. Dr. Anjanet, are you here with us now?
I'm in. Thank you.
Okay. Thank you very much, Dr. Anjanet. So, ladies and gentlemen, before I proceeded to Dr. Anjanet De Leon, I would like to briefly explain about the background of Dr. Anjanet. So, the operator, you may display the CV of Doctor, and I would like to read the summary of her background. So, Dr. Anjani De Leon is an accomplished nurse educator, diabetes specialist, and healthcare leader with more than 2 decades of experience in clinical practice, academic institution, and educational leadership. Her career is devoted to advancing diabetes care and community health through education, interprofessional collaboration, and evidence-based practice. As a board member of the Philippine Association of Diabetes Care and Education Specialists, she actively contributes to strengthening diabetes education across the Philippines, promoting interdisciplinary teamwork among nurses, physicians, dietitians, and public health professionals in the management of type 2 diabetes mellitus. Over 20 years as a clinical professor in nursing, mentoring local and international students in diabetes care and patient management. And Dr. Leons also have some research and advocacy in diabetes care. She has a scholarly work emphasized in community-based diabetes education and empowerment of patients and health workers alike, and also assessment of healthcare needs of older person with type 2 diabetes mellitus. And the most current one, mobile DSME for type 2 diabetes mellitus patients in Indonesia and the Philippines, clinical profile of type 2 DM patients in Metro Manila. So she also received some awards and recognitions. Some of them are Best Research Presenter in Philippine Nursing Research Society, and also IQA awardee, Centro Escolar University, and the current one, Best Research Awardee, CEU 2024. So dedicated to empowering both patients and health worker, we believe that Dr. De Leon's work bridges clinical care, community engagement, and academic excellence. Her initiatives continue to equip healthcare teams with the knowledge and tools to deliver holistic, sustainable care and individual with type 2 diabetes mellitus, perfectly aligning with the spirit of this international conference. So, ladies and gentlemen, for Dr. De Leon, if everything is set, then the screen is yours and you may start as you wish.
Can you share my slides, please?
Okay, the committee will do it.
Salamat pagi. Good morning, everyone. I am Anjanette De Leon, Professor Anjanette De Leon. Disclaimer lang, okay, that I am in no connection with other pharmaceutical or any medical devices. This is for educational presentation only. I hope that at the end of my talk and discussion, I can contribute to the attainment of your objectives and of your goals to the 8th conference, about empowerment in community. Okay. Sir, can you share my slide?
Yeah, we are processing it now.
All right. So my objective for today is, of course, to determine the current prevalence of diabetes worldwide and also in Southeast Asia, which includes Indonesia and the Philippines. We will also identify the key digital health tools currently used in diabetes care and management and explore the impact of this digital health technology in terms of its risks, challenges, and opportunities for patient and healthcare provider. And later on, at the end of my discussion, I would like to outline the other recommendation devices for monitoring glucose and delivering insulin from the different studies that was taken and summarize and come up with a recommendation by ADA. Next slide, please. Go on to the next slide, please. Okay, I hope I can beat the 45 minutes with a 45 slide presentation. Next slide, please. All right, now as you can see here, diabetes is really a chronic disease. Just like the first speaker have mentioned a while ago, the number of people with diabetes is rapidly increasing. So it also equates to the high healthcare costs. Even in the US, they are spending trillions of pesos for the medication and treatment and management, even complications. So as you can see here, it is projected by 2050 that in every 8 individuals, there is one person with diabetes. And 81% of adults, that is very alarming and concerning, that 81% of adults with diabetes live in a low middle income countries. Next slide, please. It also share on this slide that here 73% is reaching 185 million by 2020. So therefore, diabetes continues to rise, okay, so the traditional approaches is no longer enough. So therefore, these growing challenges has paved the way for digital transformation to enhance the prevention, monitoring, and management. Next slide. Let us clarify some concepts about digital health technology, diabetes technology, digital health transformation, and ecosystem. So when we talk about digital health technology, we talk about those devices, wearables, health information system, the software system. But when we talk of very specific about diabetes technology, so therefore it is these devices that we are using to assist the self-management, ranging from lifestyle medication to glucose monitoring and therapy adjustment. So when we talk about digital health transformation, there is now a shift towards the ecosystem of tools like that was mentioned here, the telehealth and so many others, okay? So when we talk about digital ecosystem now, it is now the interconnection of digital platform devices that work together to collect, analyze, and use the health information to improve the patient outcome. Next slide. So there is a remarkable progress through the integration of digital tool. Since we are shifting now from traditional to reactive approaches, proactive, personalized, and data-driven care. So we come to reflect and ask the following questions. So what are now the new technological developments in advancing diabetes prevention, monitoring, and treatment? So what is the role of technology in enhancing diabetes care and management? And then what are the risks, opportunities, and challenges on each devices? So later on, we will discuss gradually, slowly, and one by one. Next, please. Can you still remember this? Who can remember this? I hope we still have some, Okay, so here, as you can see here, Frederick Bunting and Charles Best discovered the first insulin as a life-saving therapy for diabetes. And it was Thomson, it was the Leonard Thomson as the first patient to receive the insulin. Then after this discovery or this breakthrough, many devices now come in front and develop, since then up to the current. Next slide, please. Can you still remember this? Yung mga generation Y, X, millennials. Okay, I know some of you can still remember these gadgets, So I hope some of you have somehow used this in the hospital. Next, please. Okay. Now, what I'm going to discuss today are the following devices that are being used now. We have the telehealth platform, we have the the CGM devices, and then the hybrid closed loop, which is more developed than the CGM, and then the mobile health app that is worldwide use nowadays, and also, next slide, and also the digital based health intervention, health education, and the most current and recent is the virtual reality tools that deliver diabetes education to a wider audience, which also include Heal the Telegram. And then the electronic health records that had been used from the start of COVID, even before the COVID-19, but it becomes more widespread in use of the electronic health record when we are locked down due to COVID-19. Next slide. Okay, so let's start with the telehealth. In this study, it tells us that telehealth usage accelerated during COVID-19 and lockdown. It really surged worldwide. And in the study of Isami et al., comprehensive literature search was carried out across multiple electronic databases. They found out that telemedicine is a transformative tool in chronic disease management, particularly in diabetes care. So they find significant improvement in patient health outcome, and its cost savings were also reported. It also increases the patient engagement and improving the hemoglobin A1C. So even aside from that, yung telehealth services also are being used for diabetes-related foot disease encounter, which overcome the geographical barriers, providing specialized care and improving patient health access and satisfaction. Next, please. Okay, so this is the same study of Xiao. In the study of Xiao, it also suggests that telehealth services contributed better glycemic control and management of other clinical outcome with type 2 diabetes. This was during pandemic, that they have a better hemoglobin A1C control compared to those receiving in-person care only during the pandemic. Next slide. So in telehealth, so what are the risks and challenges that were reported in the use of this? Although there is one of the risks is the lower smartphone ownership, okay, and limited internet access, especially on the low middle income countries, and the digital health literacy in the use, especially the aging population, contribute to the decreased telehealth use among certain populations. So there are also some challenges that we need to address, like the unclear policies on payment scheme, consent, and licensing of virtual care. So also to be included are the care provided by non-physician team members, which is very important, dietitian, nurses, podiatrists, and even social workers as necessary. But as we can see on the current trend today, there are also telehealth now that are incorporated or integrated in the EHR. So opportunities here are expanded internet access, especially on the low middle income countries, combined with universal internet connectivity among therapeutic devices such as insulin pumps, CGM, etc. And also one of the concern is the transfer of the patient data, okay, directly to EHR system, and could dramatically improve the efficacy of telehealth encounter. Next, please. Okay, so this is an example of one technology that is being used for diabetes care monitoring and controlling of blood glucose as well. So continuous glucose monitoring, at the name itself define, it's continually monitor the glucose in your body through an external device. So you can see here there is a sensor, and there is also a transmitter device, okay, that is attached to the body. And this one would give a real-time update. It has tiny sensor inserted under your skin or in your belly or in your arm. It is a sticky patch actually, and then you have the CGM sensor that estimates the glucose level in the fluid, which is very similar also with the glucose level in your blood. Okay, next please. Okay, in the study of Manove et al., there is a significant improvement in the hemoglobin A1C compared to a self-monitoring blood glucose to CGM. So same also in the study of Rothbard, that the system are safe, the CGM, and effective in both type 1 and type 2 diabetes. Actually, they found out also that this can improve quality of glycemic control, reduce the risk of hypoglycemia, and permit selection of lower target level. Next. Okay, however, there are some risks, no? In the use of digital technology, there is always the downside, right? So there might be encounter of the patient, no? And reported inaccurate readings, okay? There might be some skin irritation and infection because sometimes the sensor should stay in how many days and then you need to change it again. And this is very expensive. So sensor or transmitter failure also happens and reported. No? Disconnection or calibration error can cause data loss. So CGM connected to app or cloud platform may be vulnerable also to cybersecurity or breaches. So what are our challenges? Definitely, that as the demand rises, no, and so many devices are now existing, no, naglo-lower the cost of technology. So still, no, the high cost and accessibility, we are concerned with the low middle income countries, no. So CGM data may not easily connect also with the electronic health record or insulin pump, for example, no. And another challenge here is the digital literacy of the population. Okay. And what are the opportunities, no? Advances that it would be a non-invasive sensor and longer sensor life, no? And a real-time cloud analytics are expanding CGM role in digital diabetes management. Another opportunity is that it might work with insulin. This might work with the insulin pump, with the smartphone and AI algorithm, so that the data would be translated, transmitted, and utilized. So it would be automatic, no, to deliver insulin according to the readings or according to the result of your blood sugar. So another challenge is the patient, no, or another opportunity that the patient probably should visualize, no, glucose trends and learn how do they integrate the food, activity, and stress affect levels, no, in the technology. Okay, next please. Okay, here one is an insulin pump. Insulin pump comes with a CGM, or insulin pump usually can perform independently. However, it is recommended that there should be integration of this with other technology. An insulin pump is just like your pancreas, no? It naturally releases insulin, it delivers insulin, and it can be integrated with CGM technology to automatically increase, decrease, or stop into insulin release based on your glucose level. So here you have the pump device. You can see here the pump device. There is also a tubing and infusion set. This is where insulin is delivered from the pump here, not to the body. Then you also have a small cannula that is flexible here, inserted under the skin. Okay. Next, please. In the study of Gandhi about insulin pump in 2017 and 2011, the finding shows that insulin pump users have decreased rate of diabetic ketoacidosis. So fewer severe hypoglycemia events and reduced hospital days were noted and reported. However, there are some limitation of the research, no, that ongoing data still on diabetes technology across the span from pediatric to older adult must be expounded more and explore more. Okay, next slide. Okay, so what are the risks and challenges of an insulin pump? No, we can see here, no, yung long-term infusion site. That's why the infusion site should be rotated in the body. So because sometimes it may cause redness, itching, swelling, and local infection. So devices and supplies are expensive also, and not always converted in an insurance. In the Philippines, we call it PhilHealth, but in your financing in Indonesia, I do not know if this is converted by insurance. So wireless enabled pumps can be vulnerable to unauthorized access also or hacking, no? And another here risk is the incorrect insulin dose programming or improper pump handling can cause severe hypo or hyperglycemia if not accurate and if there is a failure on the part of this technology. What are the challenges? No, patient must learn no pump operation. However, in some pharmaceutical and medical devices company, they hire diabetes educators, and sometimes these diabetes educator provide trainings to the persons with diabetes who purchase no this medical device or this kind of technology. And another challenge to us is the regular changing of the infusion set and battery check are necessary also for safety reason. What are the opportunities? No, continuous development in a smaller amount, no, and more user-friendly insulin pump and affordable insulin pump. So expanding access in connected diabetes ecosystem, that it would not only stand alone as an insulin pump, but there should be an interconnectivity of one technology to another technology so that data will be generated as one. Next, please. Okay, another one is the hybrid closed loop system. No, there are three main components of this. So you have the CGM, no, the one here, and you have the insulin pump, where the cartridge or the insulin delivers, no, to the sensor here to the body. Okay, and you have a smart algorithm control. You have a smart algorithm controller that analyze the glucose data and then automatically adjust the insulin device. So this is more interconnected technology, no? Where you have the insulin pump, you have the CGM, you also have the algorithm. So here, next slide, please. Okay. Here in the study of Garsade in 2024, when they compare the CGM and the sub-Q insulin infusion, it showed improvements in hemoglobin A1C. But there were smaller, no, showed improvements, but smaller compared to a hybrid closed loop arm. That's why outcome were superior in hybrid closed loop arm compared with the CGM alone and subcutaneous insulin infusion. Next slide. Okay, another one is a mobile health app. Okay, what is the functionality? I know most of you have this mobile health app, no? It shows graphs and trends, no? And then it sends alert if it is high, if it is low. It also have diet and nutrition tracking, food logging, carbohydrate counting, no? Built-in nutritional databases, physical activity and exercise, integration of fitness and trackers, no? So it depends on the functionality of the mobile health app. It comes from a more simple to a more complex use or usability or functionality of the mobile health app. Okay, next, please. Here in the study of in the study of LIM about the evaluation of mobile application for patients with diabetes, it shows that out of the 12 related studies over the past 5 years of self-management, findings showed from the 5 studies, no, that there is a significant, no, reported significant system usability, ease of use, positive attitude toward use, and continued intention to use and satisfaction. While the 3 studies reported a significant decrease also in hemoglobin A1C level after using a mobile app. So among these 3 studies that evaluated both functionality and usability, there is one study that observed a significant decrease in A1C level and improvement. Okay. Next. Here for the risk, I'm sorry, going back. Okay, for the risk of using the mobile health app, sometimes there is inaccuracy of encoding data coming from the patient or coming from the client. So unvalidated app algorithm also, okay, as reported, unclear data ownership, who sometimes that it depends who created the mobile app functionality, and then who owns the data. Okay, so that's one question pagdating in terms of the privacy, okay, of data. Incompatibility with other devices, digital fatigue also is a concern, and data breaches or hacking is also a concern. So what are the challenges, Since there is no standard method for evaluating app development, the involvement of the users should be considered, like the developers, the clinical experts, and considered also essential during the app development stage of the mobile app. So opportunities, also future diabetes app should include features for complication prevention, and app should enable a real-time interactive communication. Okay, next please. I know you are familiar with the insulin pen. Actually, it becomes available in 1985, and eliminated the need to draw up insulin from a vial with the insulin pen. Okay, before in the hospital, we still have to aspirate the insulin from the vial with an ordinary syringe, But it becomes more advanced, that it becomes more close to dosing, more efficient, accurate in terms of delivering insulin using the insulin pen. Okay, and both disposable and reusable pens are available at time. It also showed that insulin pen have showed improved dosing accuracy and consistency compared with the syringes, because it's calculate each dose based on the current blood glucose level, on carbohydrate amount, meal size, etc. Okay. Next, please. Okay, so what is the role here of the smart insulin pen? This smart system calculates and tracks doses and provide helpful reminders. There are also alerts, the cap itself of the insulin, sorry for that. Somebody calling. I'm sorry. I'm sorry. Okay, let me continue. Okay, I'm sorry for that. Okay, here. And then a smaller pen with connectivity also. Okay, let's see. Okay. Calculate the track and dose. A smart pen with connectivity also allows for the potential to send reminders in the case and of missed doses when paired with an appropriate mobile app. So smart insulin pen with connectivity improve communication with the healthcare providers through data sharing and resulting in robust transparency. Okay. Next, please. Okay. Insulin pen with connectivity include a low level of complexity with automatic recording, dose recommendation, and reminders. Very convenient, no need for the patient to wear an additional device. Long battery life, automatic changes to time zone, and data integration of capability. Hopefully in the future, we can do this. Okay, but definitely, no, some of devices are the technology is advancing through every year. That's why it's possible that all of this technology, okay, would really become more complex and more user friendly, no, based on the researches and based on the result of the researches and recommendations also. Next, please. Okay, what are some of the challenges? Next slide, please. Connected smart insulin pen depend on companion app for data collection, but standardized interoperability across smart diabetes devices remains limited. Okay, and simple and realized technical solutions are needed to ensure that all types of smart insulin can be seamlessly integrated in the medical use. Okay. Done. Smart pen also have potential to improve dosing accuracy and lead to more appropriate or safer dosage decision. Automatic data capture of insulin dose data, particularly when paired with glucose data, can help counter therapeutic inertia and allow patient and providers to make data-driven decision. Okay, some of the risks, no, of this is malfunction or connectivity error. So the pen may fail to record or transmit those data correctly via Bluetooth or NFC. Battery dependence also, no? It requires also power. And of course, glitches in the companion app can cause incorrect insulin tracking or data loss. Compatibility issue is also a concern in using some smart pen. It only works with specific app, smartphone, or insulin type. Next, please. Okay. Here is hold on. Another is a telegram base. No? A telegram method is a communication technique used in health teaching where important health messages are delivered briefly and directly. So focusing only on essential information, just like a telegram. Who among here have are used of receiving telegram in the past? No, it's just like a telegram, a very short information, no, that that was given. And when educators use telegram, they usually use this same app to create telegram channel in a larger audience. Okay, they create group, they send messages, they send videos and even infographics about health topics. No, they can also conduct poll quizzes for engagement. Okay, this is very useful in delivering health education, but very precise and very short information. The virtual reality is another technology and very current technology now that is advancing. It's a simulated experience that employs 3D, near eye display, that pose tracking to give the user an immersive feel of a virtual role. However, it is expensive, yung virtual reality. In some, because it becomes a demand, probably it lowers the cost, But this is good in home and healthcare, for persons with diabetes, to prevent diabetes also, especially complications of type 1 and type 2 diabetes. This type of technology also is encouraging and motivating on the part of the client, especially if they are to watch the real exercise, and also and other diet, okay, meal example, sample of meals, and many others, Next, please. Okay. The Telegram, okay, is a digital platform, okay, that provides comprehensive educational content, including interactive modules, visual aid, tailored individuals, enabling patients to receive support and education from the comfort of their home. It also engages patients actively in self-care process through user-friendly interface. Okay? Digital health intervention delivered through Telegram platform have been shown to enhance knowledge and self-efficacy and self-management according to the study of Shaban et al. In 2024. So it highlights the effectiveness of tailored digital strategies in complementing traditional healthcare practices and transforming diabetes management. Okay. Next, please. What are the risks and challenges of the Telegram method? No? To address the potential challenges such as privacy and security concern, digital literacy among older patients, no, is also a problem, and even the means of language, the language that a person use, no. And the need of ongoing technical support is also necessary, especially on the aging population. Here, the language and cultural relevance is also a concern. So it should be culturally sensitive and use language that suits the target population's literacy level. So what are the opportunities? A wider reach and accessibility. Telegram can connect healthcare providers with the larger audiences instantly, even across distant area. And there must be a real-time communication. Health educators can send instant updates, reminders, and feedback of patient also. Next slide. How about virtual reality? No? There are three components, no, of this virtual reality in the management of diabetes. No? Education and training is one, where we can use the VR, where our target are the clinicians, the adults with diabetes, and children with diabetes, especially the children are much in fun, no, using this. And then prevention of diabetes complication also with virtual reality. This was reported that it encourages, no, persons with diabetes, especially doing exercises, healthy behavior, stress reduction, and healthy eating choices. And another is the treatment and management of diabetes with VR includes augmented carbohydrates, estimation, tracking, and many others. No, what is the need? A VR training for adults and children with diabetes can be especially beneficial in rural areas. This is possible in the community, though it is expensive. But if we can invest on this would somehow can manage and control their diabetes, especially for type 1 diabetes, where lower literacy, higher risk of delayed diagnosis, and limited access to diabetologists. Next slide. Some VR have compatible, no, software that can be expensive, no, and limiting use in low resource or rural settings, especially in the low middle income countries. A stable internet is also necessary. Updated devices and technical support are necessary for smooth operation of virtual reality. And I hopefully, as one of by 2030, no, it is expected to expand, including the eating habits, facilitating weight loss, increasing physical activity, and other lifestyle changes. The only concern here in virtual reality is coming up with a standard information. Where do they get, no, the information in integrating all of this in the virtual reality? So when future VR systems are being developed, they should include a wide range of stakeholder input, like the people living with diabetes primarily should be included, the pharmacists, the practitioners, and diabetes educator. However, no, on the negative side or downside of this, no, some patient can experience eye strain, dizziness, nausea, motion sickness, no, risk of accidents or injury while using it. It also have psychological effect like confusion between virtual and real experience, no, and many others. The lack of standardization of data, okay, is also a challenge to have a universal safety and content guidelines. create an interactive, engaging, and experiential learning environment that improve retention and participation in the future technology using the virtual reality. Next, please. The electronic health record, modern EHR not only store patient record, but also actively support clinical decision making. Okay, it also improves coordination. Okay, through researches, because even previously, even before 2020, EHR have been improving. Okay, nowadays, even in the Philippines, it is now integrated. So all healthcare professionals are now integrated, are now part in the use of EHR. And even health education is already conducted in the EHR. So the integration of clinical decision-making, care coordination, and enhanced patient engagement is necessary. So therefore, the modern EHR now, I believe, have already address all the concerns and reported issues in the use of EHR. So they provide tools for real-time monitoring, track chronic disease management, reduce error through alerts, and enable secure communication between patient and healthcare team. Next, please. EHR is not designed to use user-friendly for patient, especially with limited health literacy. Okay, so this is also a challenge to everyone. EHR face challenges in organizing and presenting data efficiently. Primary care physicians, the main data contributors, are often overwhelmed by the data entry and administrative tasks. So advanced EHR should streamline the workflow, meet actual needs, and display information, okay, with the current features. Increasing EHR use can unintentionally create extra work for clinicians, So it contributes to inefficient workflow, poorer communication, and over-reliance on technology. Many EHR tools were developed without enough input from providers and also patients. So what are the opportunities of EHR? Okay. EHR have advanced benefit for both patient and clinician, especially to chronic disease management, by providing clinical decision support, drug interaction, enhancing communication in the EHR, and enabling detailed tracking of patient progress without unnecessary testing. So setting up online groups where people with diabetes can connect, share also their experiences, support, and each other. Although we can see it on the Facebook nowadays that there are support group having the same page of all persons with diabetes. But hopefully this would be integrated also in the EHR. New diabetes technology should be designed and used so that all patients, including those with limited English, low literacy, or other vulnerability, can access and benefit from them, and helping to reduce disparity in care. Equity is a problem also. Electronic health record have great potential as a data source for clinical researchers to use. Next slide. Healthcare team involvement is essential. Okay. Next slide. Healthcare team is essential in the use of digital health technology. It requires teamwork among various professionals. Interdisciplinary collaboration ensures that technology is safe, effective, and patient-centered. Next, please. I would like to share with you, I have 10 minutes more, please. I would like to share with you with the general device principle that was recommended by ADA. This is the most recent, 2025, These are some of the recommendations of Association of Diabetes, American Association of Diabetes. The diabetes devices should be offered to people with diabetes. And initiation of continuous CGM should be offered to people with type 1 diabetes in the disease, even at time of diagnosis. So the type and selection of devices should be individualized based on person-specific needs, circumstances, preferences, and skill level. In the setting of an individual whose diabetes is partially or wholly managed by someone else, like a young child, okay, for example, the caregiver's skills and preferences are integral to the decision-making process. Next. When prescribing a device, ensure that people with diabetes and caregivers receive initial and ongoing education and training, either in person or remotely, and ongoing evaluation of technique, result, and the ability to utilize data, including uploading or sharing data to monitor and adjust therapy. Healthcare professionals working with diabetes technology should ensure that competencies are established within the healthcare team based on their specific role and within specific setting. People with diabetes who have been using CGM, subcutaneous insulin infusion, or automated insulin device for diabetes management should have continued access across third-party payers, regardless of age or A1C level. Next slide. Students should be supported at school in the use of diabetes technology, such as CGM system, the CSI or insulin pen, and the automatic insulin device system as recommended or prescribed by the healthcare team. Recommended early initiation, including at diagnosis of all these devices, depending on a person or caregiver's needs and preferences. Standardized report for all of this technology and connected insulin devices with a minimum single pay report, such as the ambulatory glucose profile and weekly summary, should be available and utilized. Option for daily and weekly report and raw data should be available. And lastly, consider contributing or combining technology such as CGM, insulin pump, or any diabetes app with online or virtual coaching to improve glycemic outcome and individual and with diabetes. I hope the ADA recommendation summarize all the studies, all the technology and devices that was presented today. So let me end by saying there is no one-size-fits-all approach to technology use in people with diabetes. The selection and integration of digital tool should be individualized carefully, aligned with each person's unique needs, life circumstances, preferences, and level of technological skill. And here are my references. Thank you very much.
Thank you very much, Professor De Leon, for the eye-opening presentation. So we have seen that how we can leverage our digital advancement in managing diabetes, but still there is no one size fits all. So we have to adjust in alignment with our objectives. Thank you very much, Professor De Leon. So now we are entering the Q&A session, ladies and gentlemen. But before that, I would like to check whether our first speaker and second speaker are already standby in this room. Dr. Hadija, are you here with us now? Dr. Hadija, are you still with us? And the second speaker, Dr. Judiono, are you still with us as well?
Yes, Pak Willy, I am ready.
Thank you, sir. All right, ladies and gentlemen, there were plenty questions that have been submitted to our committee. So I would like to ask the committee to display the questions for maybe for the second and the third speaker, for Dr. Judiono and Professor De Leon first, before we move to Dr. Hadija. while we are waiting for her to be here with us. So, the operator, can you please display the questions for Professor De Leon and also Dr. Giuliano?
Some questions I've already in the message, Pak Willy. I have
Yeah,
already answer.
Yeah, thank you, Dr. Giuliano. We saw it. Maybe we're still waiting for the question to be displayed. Okay, thank you very much, Dr. Hadija, for being with us now. We are still waiting for the question to be displayed, ladies and gentlemen. Okay, if maybe I can read it because the operator is still preparing for the display. The first question for Professor De Leon is like this. Since okay, I will display it myself. Is it on the screen now? Okay, while we're waiting to be proceed to display it, I will read it. The question from the participant for Professor De Leon. Since CGM is so costly, do you have any experience about more affordable things that can prevent patients in hyperglycemia occurrence? For example, regarding carb counting. Maybe for Professor De Leon first.
Okay. Thank you for that question. No. Alternative tool or technology of CGM. I think we go back with the traditional of the SMBG, the self-management blood glucose monitoring. Remember that CGM, the CGM, the trend is it would work out and advance with more features and interconnectivity. So we expect a higher cost in terms of the use of these devices. But for now, since some of the people cannot afford yet, to buy a CGM, this kind of technology, let's still go back with the traditional of SMBG, but that's still another technology, the SMBG, a more simple technology, I mean.
Okay, thank you very much, Professor De Leon. Do you have any explanation about what about regarding the carb counting? Are there any current digital innovation regarding carbohydrate counting that can be used?
I think one of the features of the mobile app. The mobile app is there is a carb counting.
Nah, bagaimana nanti pemeriksaannya?
Really,
Dilakukan pada
can you
usia
please
bayi 24 sampai
turn off the
48 jam
microphone
atau
for the other?
sesaat sebelum kurang dari 24 jam.
Okay, so we can use the mobile app where features, we can utilize the features like carb counting, and from there we can adjust and modify our diet and also do some alternative interventions to manage the diabetes or control the blood glucose.
Okay, thank you very much, Professor De Leon, for the explanation.
Tapi kalau sedang bayi-bayi
Not sure about the disturbance. Can the committee handle this before we proceed?
Answer number 2, Pak
Yeah.
Willy. Yeah.
Okay.
The question is, what kind of communication channel are expected from the result of collaboration? The kind communication channel expected from the result of the collaboration typically include a mix of formal, informal, and digital to ensure smooth coordination, transparency, and also efficiency. I mean that all channels that we can use, Pak Willy, because sometimes we not only formal, and sometimes also we can use informal. So that way, during the communication, it can be delivered with the informative and coordination. I mean, it can be easy to absorb the patient and also all team who participate in the IPA, Pak Willy. I mean that this is some kind of channel that we can use, Pak Willy.
Okay,
The
thank you.
second, what step must be taken to achieve of this? Yeah, to establish and maintain an effective communication channel, in collaboration, several steps should be taken. The first, all the team should be define communicative objective communication this one. I mean that, well, we can define objective through the communication this one among the team. It means that it will be easy for the patient to absorb information and also suggestion from the team. The secondly, we also need to define or identify which stakeholder and role in the communication this one. I mean that when we can decide or it mean can maintain, we know about the stakeholder, it mean can easily to understand during of the communication this one. The third is please select appropriate communication channel. Yeah, it means what I said that the first, this is formal, informal, or collaborative work in this communication this one, because when we understand with our target objective, it can be easily be understood patient and also team during communication this one. The fourth, we use established communication protocol. I mean that during the communication, it should the communication must be delivered with communication protocol. I mean, all team and also patient must be understood about this one, Pak Willy. This is my short answer. If we need more detail, I would like to send to the committee. Thank you, Pak Willy.
All right. Thank you very much, Dr. Juliana, for the comprehensive explanation. Now, for the question for Dr. Hariza. What about Brunei? How can you describe the government willingness as one of the enablers to invest more in research as the foundation in policy making?
Thank you very much for the questions. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Yes, in Brunei, mainly for health-related research, usually we have a collaboration between the University Brunei Darussalam, and the Ministry of Health. So usually the funding comes from the University Brunei Darussalam. However, if we have a large study involving different ministries, involving different departments, so we can apply for what we call as the CREATES, CREATES, CREATES funding. The CREATES funding is a funding that is provided by the Ministry of Information Technology. They will give the funding as much as 200,000 Brunei dollars or even as much as $1 million Brunei, as long as it is have strong justification and make changes to Brunei. So, but again, as problem as in any other situation, the problem with funding from the government is that it might take a while for it to be processed. That's one thing. And the second thing is it require our money to be used first, and then the payment is based on reimbursement. So if your team doesn't have money, if our team doesn't have money, then it is quite a disadvantage to us because we have to really have money to use our own money first, then we ask for the reimbursement. Yes. Thank you.
Okay. Thank you very much, Dr. Hadija, for the explanation. So, ladies and gentlemen, since we are still very much in time, we still have more questions to be discussed. Can we move to the next one? Yep, this one. I would read from Dr. Hadija first. What are the main studies and concrete steps taken by ASEAN countries to unify their vision and mission in developing public health in their countries? And why is it always countries outside ASEAN that provide assistance in healthcare sector to Indonesia, Malaysia, and other countries in ASEAN?
Thank you very much for the questions. What are the main studies and concrete steps taken by ASEAN countries to unify their vision? So I think as far as I'm concerned, as far as ASEAN is concerned, I do not know any information about it, but the World Health Organization has been working together with us in Brunei for our nutrition studies. Okay, we use the steps questionnaire. We have been doing it with World Health Organization and are now currently in the reporting. We have finished off our data collection, although we are short of participants, but we are writing at the moment and writing the report. So I think that's one. But for the ASEAN countries, what I can see is we have last 2 weeks we have recently have ASEAN Center for Aging Research and Innovation who come over to Brunei, and we have a meeting, and we also have some funding from ASEAN Center in terms of non-communicable diseases among the aging population. And we conduct a study on, we are thinking of conducting study on integrative care of the older person. However, we were not the main country, the primary country, or the leading country. What I find out is most of the country, as you said in your second question, is most of the country was from most of the research was from Indonesia. In the shortlisted, when I see the shortlisted, around 5 out of 10 are from Indonesia. So I guess Indonesia, because it is a very big country, and the ASEAN Center are looking more focused on bigger countries. Even Malaysia do not, only 1 or 2 shortlisted, but most of it are from Indonesia. So the question for why, I think depending on how much funding do you have in your country, okay? So usually, even if we ask funding from other organization, they will want some match funding from our country. So basically, like in Brunei, we can get easily can get 15,000-20,000 Brunei dollars. But when I sit down with my Indonesian friend from different university in Indonesia, I understand that even to get 2,000 Brunei dollars or 2,000 US dollars is not as easy. So again, why the provision of assistance from other countries or from ASEAN or from other funding, that might answer the questions in terms of how much money can the university give to a researcher. Okay, thank you.
All right, thank you very much, Dr. Hadiza. So we will move to the next question for Dr. Judiono. What are the challenges in applying IPC in Puskesmas level in order to manage type 2 diabetes mellitus?
Thank you, Pak Billy. I would like to answer this question. There are several challenges that we face about implementing of the IPC this one. The first is system related to the system. Secondly, human resources, and the third is policy support. For the first structural system and structure and organization barrier, often limit effective teamwork, because we know that in the Puskesmas, there is usually very limit human resources in this institution. So that why it is some barrier that we can found in the implementing of the IPC in the Puskesmas. The second is human resources constraint remain key issue. The number health trained professional with familiar with IPC also very very small. I mean that very limited. So that why it is some barrier that we can find while in the implementing in the Puskesmas, Pak Willy. The third, limited policy and financial support that it affect on the weakness sustainability in the Puskesmas. I mean that funding at the Puskesmas usually is not directed for the one program, but it is will be support by to support all the program in the Puskesmas. It means that the not specifically for supporting like diabetes mellitus only. So that why it is some kind of the challenges that we can find there in the Puskesmas. But if we can implement it, make a pilot project in the community, I think we can try, because some part of in the public hospital that I know through diabetes educator, it means with implementing collaborative teamwork in the human resources with variety of the profession. I mean, it is very good, because I know yeah, IPC that implemented in the public hospital, I think is better. So that why if APC will be implemented in the Puskesmas, it means we must conducting a serial of training for supporting human resources in the Puskesmas. But I mean that it is not easy, because some part of limited of the human resources in the Puskesmas is one. It is my answer, Pak Willy. I hope the penanya understand about this one, Pak Ali. Thank you, Pak Willy.
Thank you very much, Dr. Judiono. Now we move to the third question for Professor De Leon. How does the government support the development of digital health technology in diabetes care.
Yeah, good morning. It's good afternoon. Okay. The same thing, no? Policy makers should draft, no? Although in the Philippines, no, it's still there is a bill, but it's not yet a law, no. But in other countries, it is well established in terms of the digital use of digital health technology. They are well funded, of course, and they are well supported by the government. However, there are some middle low income countries and developing countries that still in the process of utilizing digital health technology. So they are still crafting some of the laws, some of the frameworks, but it should be more specific, accommodating the digital integration, okay, of all patient, and also the privacy, okay, of information should also be well stated. The payment scheme at the same time, all right, and also the role of all of these healthcare professionals, no, in managing and controlling diabetes, rising of diabetes, especially complications. Not only policy, regulation, integration of data, it also needs training, no, because most of the population are not digitally inclined in the use of technology. So education and training should be intensified as well, and at the same time, okay, the the funding and the cost, of course, should also be given consideration. If necessary, come up with a public and private partnership as well. So I think it would be more successful, no, if the government would really support, no, all of this digital technology to come as one in terms of their interconnectivity, having one data source and having all devices not stand alone, but rather connected, interconnected with one another, would become more effective in terms of the outcome or patient outcome in controlling and preventing, no, diabetes. Thank you.
Thank you very much for the explanation, Professor De Leon. I think we still have some questions left. Okay, this one should be the last. Okay, it's for only Dr. Judiono and Dr. Hadiza. I would read that. For Dr. Judiono, what are some real examples of successful interprofessional collaboration programs in Indonesia or maybe other countries? You may answer it, Dr. Judiono.
Yeah, thank you, Pak Willy. I would like to answer this question. What are some real example successful interpersonal collaboration program in the Indonesia and other countries? We know that Indonesian in the community is very difficult, Pak Willy. I said that my experience during conducting in the community, I try to build a team in the community. But again, we invite from the Puskesmas team and also from other professional in the Polytechnic of Health. Also, we still build Pak Willy. I mean that in the community is very little bit some barriers that we facing in this case. But in the public hospital, it has been implemented Pak Willy. So that way in the public hospital, it is very easy. But in the community, because some limited human resources, we found in the Puskesmas, it is not easy to be implemented, Pak Willy. But in the other country, I mean, have already done this one. I think it's better. But Indonesia, we facing limited of the human resources in the public hospital. This one, Pak Willy. Thank you, Pak Willy.
Okay, thank you very much, Dr. Judiono. Now we move to the next question for Dr. Hadiza. How can collaborative strategies between health profession be developed sustainably to improve the management of type 2 diabetes mellitus at the community level?
Thank you so much for the questions. Yeah, the question is how can collaborative strategies between health professions? Yeah, so we take example because since we have been talking about diabetes from the beginning, so probably let's take diabetes mellitus as an example. I can only talk based on my experience. Okay, so healthcare professions, there are many. We have doctors, we have podiatrists, we have nurses, we have physiotherapy, we have midwife, and so forth. Okay, so in one of the research that I supervise for a PhD study, it is a research that is targeted into reforming policy in Brunei in terms of using the new technique in identifying what we call as peripheral arterial diseases among diabetes mellitus patients. So these students is a podiatrist, and as you can see, I'm a nurse by background. So I am working with her closely. So that is one way of collaboration. And we also have senior podiatrists, and we have one physiotherapist who are working with us as well to look into what are the exercises that the aging population has been doing in terms of preventing the occurrence of peripheral arterial diseases. So this is one of the way. One of the way is to identify the strategies include identifying the topic, then identifying the people who are going to work together. Third, identify what are the kind of policy changes or what are the kind of translation into practice that we are going to do. I believe Indonesia has been very fantastic in translational research, in translating research into practice, because I've been working with a lot of Indonesian colleagues before, and one of the things that they did is the innovation. Yeah, and also the evidence, introducing new evidence into practice, and then you also involved with patenting, right, in Indonesia. So I think if you ask me about the strategy, the first thing is, because this is in the community level, is to identify who are the healthcare profession that you are going to work with. Is it the doctors? Is it going to be involving the podiatrists? Is it going to be involved the nurses, or even physiotherapy? Okay, and so many people. That's the second thing. Once you got the topic that interests you, the second thing is identify the people who are going to work with you. Number three is we would like also to maybe include, as I mentioned in my lecture just now, we might also want to include community. Okay, the community in our research, because if you involve the community, they are the stakeholders, they are the main users of our service. They are the one who wanted improvement in their service. Okay, because if we do it on our side from the researcher or from the academic point of view, we are not even in the clinical practice. How do we know that these are the kind of things that the patients want? Okay, but if we involve the patients, we know what the patients want. We know what are the kind of care that we have been given. Has it been within the quality, or is it under quality? So community can be involved in our research as well. Okay, and then whole of nation approach, all the ministries. Yeah, what are the kind of things that they can contribute for involving in the research? In that way, you have a lot of people. At least if one or two discontinue the research, you still have at least 8 of more than five organizations who are going to sustain the kind of research. But bearing that in mind, the research area that we wanted to do in the community, you have to identify what is it, what are the things that we wanted to change. Okay, so for example, just now I mentioned we are using a combination of using the machine for identifying the arterial diseases. Yeah. Secondly, is through focus group discussion on how it can affect their quality of life and what are the kind of things that they wanted to have for their care. Okay, and thirdly, we also use modern instruments, which we are also testing for our peripheral arterial diseases. So I think that's one of the things that I can talk about. You can always email me if you want more information. Yeah, so we can set the time for Professor De Leon to answer questions asked for her. Thank you.
Okay, thank you very much, Dr. Hadiza. Now we move to the final questions for Professor De Leon. What are the main functions commonly available in mobile apps for diabetes management? Maybe someone is going to develop a new apps, so you can give the suggestions.
Yeah, okay. Actually, as I mentioned a while ago about the functionality of the mobile app, no, it is just barely inputting some of your health indicators like your blood glucose, your diet, your exercise, your duration, your frequency, and then it's time to take your medicine. There is an alarm, there is a feedback, and there is also a graph that would, that would show how your blood glucose improves or increases or lower down, so that the next visit with your doctor you have something to show documented, and this will be noted by doctor for any further treatment and management and control. So actually it depends also on how other developers would like to connect some other functions of the app that is necessary for diabetes management. But then what is important, just like what the other recommendation is, that there must be a connectivity of all this app into one, having one source of data that is generated by all healthcare professionals. I think that's it. Thank you.
All right, thank you very much, Professor De Leon. So, yeah, ladies and gentlemen, distinguished speakers and participants, actually, for the moment like this, we surely wanted to discuss more and more. Unfortunately, due to the limited time available, we have to put an end to this wonderful session in this morning. So as we come to the closing of this inspiring session of this international conference, I would like to convey some words like, in today's discussion, we have truly reflected the power of collaboration, where science, compassion, and shared commitment converts to improve the lives of individuals and communities. Our distinguished speakers have enlightened us with valuable perspectives in international level or in their own local countries, from Brunei, from the Philippines, and from Indonesia. And we are more than grateful for having all of the speakers today. Thank you very much once again for Dr. Hadiza, Dr. Judiono, and Professor De Leon.
Thank
Each
you.
of your enlightenment has provided us the new insightful for the new chapter in our endeavor in managing diabetes mellitus. So may the insights we gain today inspire continued collaboration, innovation, and compassion as we move forward in our shared mission of achieving healthier and more resilient communities. Thank you once again for your active participation. I now officially close this session and look forward to seeing all of you in our next conference. And also, thank you very much and have a wonderful day. And back to the MC. Thank you very much.
Thank you, Pak Billy. And also, warm regard to Prof. Anjani and also Dr. Khadijah.
Thank you very much.
I'm still answering some of their question in the
Thank you
chat
very much,
box.
Professor.
Anyway, I have answered all. Thank you so much,
Thank you very much,
Johan.
Professor.
Thank
So,
you.
actually, we are going to hand the certificate to each of the participants or the committee ready for displaying it. So we would like to invite the leader of our institution that may come and hand this certificate to our speaker of this morning session. Mr. Dicky, do we have Mr. Dicky here? Okay, maybe I would like to convey our deep gratitude for each of the speakers that have delivered the wonderful materials for us today. So these are the certificate that will be delivered to each of the speaker. The first one for Dr. Hariza binti Haji Abdul Mumin as the speaker of this morning session, and also the next one for Dr. Junior MPS, and also the last but not least for Professor De Leon. Thank you very much for our wonderful speakers of today. I now officially return this screen and opportunity to the MC. Thank you very much.
What an excellent presentation from our speakers and interesting topic. Thank you so much, Mr. Johannes Willy Helm, Master of Science, for that insightful session. What an incredible conversation we have had today. And a big thank for our speakers, Dr. Khadijah binti Haji Abdul Mukmin, Dr. Judiono, Dr. Anjanet De Leon, and for sharing such valuable knowledge. I'm sure we all walk away with new perspective and ideas to apply in our own work. Once again, thank you to our amazing speaker and moderator for this session. Ladies and gentlemen, now we will enter the break time. On behalf of the committee, we would like to thank all the participants as well as the speaker and the moderator for all the enthusiasm in participating in this morning's session. We would like to inform that there will be another amazing speakers after the break in afternoon session about interprofessional synergy in type 2 diabetes management. A Southeast Asian perspective, strengthening health resilience through community-based diabetes intervention, integrating faith-based and community engagement strategies in diabetes mellitus type 2 prevention, lesson from Malaysia. All participants, please join again in Zoom at 1 p.m. Thank you.
Politeknik Kesehatan Kementerian Kesehatan Bandung, or Poltekkes Kemenkes Bandung, is a state vocational higher education institution under the Ministry of Health of the Republic of Indonesia. As a strategic center for health education, Poltekkes Kemenkes Bandung is dedicated to producing professional, ethical, and globally competitive healthcare professionals. Poltekkes Kemenkes Bandung is located at Jalan Pajajaran number 56, Bandung City, West Java. Bandung is known as a cool and comfortable educational city. Our vision is to be a leading health polytechnic, excelling in applied technology, character development, and global competitiveness. This vision guides our every step as we grow and contribute to healthcare, both nationally and internationally. To achieve this vision, Polkesban Bandung is committed to 7 core missions. First, provide high-quality education aligned with global orientation in applied health science and technology, producing graduates of strong character. Second, conduct innovative, applied technology-based research that leverages local resources and wisdom while empowering communities. Third, implement innovative community service initiatives that have a broad impact using research to strengthen quality education. Fourth, foster partnerships with national and international stakeholders for mutual progress. Fifth, develop new educational programs to meet the evolving demands of health science and technology. Sixth, cultivate an integrated and ethical workforce to ensure good and green governance, operating with transparency and accountability as a public service institution. 7. Lead health transformation by establishing a center of excellence for diabetes mellitus education, integrated into our core academic activities of teaching, research, and community service. Polkesban Bandung has the following human resources. Polkesban Bandung offers a variety of academic programs designed to train competent healthcare professionals. Our departments include the Department of Nursing, the Diploma of Nursing program in Bogor, Department of Midwifery, the Diploma of Midwifery program in Bogor, the Diploma of Midwifery program in Karawang, the Department of Environmental Health, the Department of Pharmacy, the Department of Nutrition, the Department of Dental Health, the Department of Medical Laboratory. Those campuses are spread across several cities. Campus A is in Bandung. Campus B is in Cimahi. Campus C is in Karawang. And Campus D is in Bogor. Polkesban Bandung achieved the highest 100% competency test pass rate in 2024 at the national level. Students and lecturers at Polkesban Bandung not only excel in academics, but also actively excel in various activities, including research, student organizations, community service, and local, national, and international competitions. The numerous awards they have won prove their strong competitive spirit and ability to bring recognition to our institution. To support a comfortable and innovative learning environment, Polkesban Bandung provides various facilities, including interactive classrooms, modern laboratories, a library, a network of partner hospitals, sports facilities, and student dormitories. These resources are designed to help students grow holistically.
As the director of Polkesban Bandung, we remain firmly committed to upholding educational quality, driving innovation, and making tangible contributions to the advancement of national health. Through education, research, and community engagement, we are confident that Polkesban Bandung will consistently produce generations of healthcare professionals who demonstrate integrity, excellence, and competitiveness at the global level.
With a clear vision and focused mission, Poltekkes Bandung is ready to produce professional, ethical, and highly dedicated healthcare professionals. Together, let's create a healthier Indonesia. Politeknik Kesehatan Kementerian Kesehatan Bandung, or Poltekkes Bandung, is a state vocational higher education institution under the Ministry of Health of the Republic of Indonesia. As a strategic center for health education, Poltekkes Bandung is dedicated to producing professional, ethical, and globally competitive healthcare professionals. Poltekkes Bandung is located at Jalan Pajajaran number 56, Bandung City, West Java. Bandung is known as a cool and comfortable educational city. Our vision is to be a leading health polytechnic, excelling in applied technology, character development, and global competitiveness. This vision guides our every step as we grow and contribute to healthcare, both nationally and internationally. To achieve this vision, Poltekkes Bandung is committed to 7 core missions. First, provide high-quality education aligned with global orientation in applied health science and technology, producing graduates of strong character. Second, conduct innovative applied technology-based research that leverages local resources and wisdom while empowering communities. Third, implement innovative community service initiatives that have a broad impact using research to strengthen quality education. Fourth, foster partnerships with national and international stakeholders for mutual progress. Fifth, develop new educational programs to meet the evolving demands of health science and technology. Sixth, cultivate an integrated and ethical workforce to ensure good and clean governance, operating with transparency and accountability as a public service institution. 7. Lead health transformation by establishing a center of excellence for diabetes mellitus education, integrated into our core academic activities of teaching, research, and community service. Poltekkes Bandung has the following human resources. Poltekkes Bandung offers a variety of academic programs designed to train competent healthcare professionals. Our departments include the Department of Nursing, the Diploma of Nursing program in Bogor, Department of Midwifery, the Diploma of Midwifery program in Bogor, the Diploma of Midwifery program in Karawang, the Department of Environmental Health, the Department of Pharmacy, the Department of Nutrition, the Department of Dental Health, the Department of Medical Laboratory Technology, and Department of Health Promotion. Those campuses are spread across several cities. Campus A is in Bandung. Campus B is in Cimahi. Campus C is in Karawang. And Campus D is in Bogor. Poltekkes Bandung achieved the highest 100% competency test pass rate in 2024 at the national level. Students and lecturers at Poltekkes Bandung not only excel in academics, but also actively excel in various activities, including research, student organizations, community service, and local, national, and international competitions. The numerous awards they have won prove their strong competitive spirit and ability to bring recognition to our institution. To support a comfortable and innovative learning environment, Poltekkes Bandung provides various facilities, including interactive classrooms, modern laboratories, a library, a network of partner hospitals, sports facilities, and student dormitories. These resources are designed to help students grow holistically.
As the director of Poltekkes Bandung, we remain firmly committed to upholding educational quality, driving innovation, and making tangible contributions to the advancement of national health. Through education, research, and community engagement, we are confident that Poltekkes Bandung will consistently produce generations of healthcare professionals who demonstrate integrity, excellence, and competitiveness at the global level.
With a clear vision and focused mission, Poltekkes Bandung is ready to produce professional, ethical, and highly dedicated healthcare professionals. Together, let's create a healthier Indonesia. Politeknik Kesehatan Kementerian Kesehatan Bandung, or Poltekkes Bandung, is a state vocational higher education institution under the Ministry of Health of the Republic of Indonesia. As a strategic center for health education, Poltekkes Bandung is dedicated to producing professional, ethical, and globally competitive healthcare professionals. Poltekkes Bandung is located at Jalan Pajajaran number 56, Bandung City, West Java. Bandung is known as a cool and comfortable educational city. Our vision is to be a leading health polytechnic, excelling in applied technology, character development, and global competitiveness. This vision guides our every step as we grow and contribute to healthcare, both nationally and internationally. To achieve this vision, Poltekkes Bandung is committed to 7 core missions. First, provide high-quality education aligned with global orientation in applied health science and technology, producing graduates of strong character. Second, conduct innovative applied technology-based research that leverages local resources and wisdom while empowering communities. Third, implement innovative community service initiatives that have a broad impact using research to strengthen quality education. Fourth, foster partnerships with national and international stakeholders for mutual progress. Fifth, develop new educational programs to meet the evolving demands of health science and technology. Sixth, cultivate an integrated and ethical workforce to ensure good and clean governance, operating with transparency and accountability as a public service institution. 7. Lead health transformation by establishing a center of excellence for diabetes mellitus education, integrated into our core academic activities of teaching, research, and community service. Poltekkes Kemenkes Bandung has the following human resources. Poltekkes Kemenkes Bandung offers a variety of academic programs designed to train competent healthcare professionals. Our departments include the Department of Nursing, the Diploma of Nursing program in Bogor, Department of Midwifery, the Diploma of Midwifery program in Bogor, the Diploma of Midwifery program in Karawang, the Department of Environmental Health, the Department of Pharmacy, the Department of Nutrition, the Department of Dental Health, the Department of Medical Laboratory Technology, and Department of Health Promotion. Those campuses are spread across several cities. Campus A is in Bandung. Campus B is in Cimahi. Campus C is in Karawang. And Campus D is in Bogor. Poltekkes Kemenkes Bandung achieved the highest 100% competency test pass rate in 2024 at the national level. Students and lecturers at Poltekkes Kemenkes Bandung not only excel in academics, but also actively excel in various activities, including research, student organizations, community service, and local, national, and international competitions. The numerous awards they have won prove their strong competitive spirit and ability to bring recognition to our institution. To support a comfortable and innovative learning environment, Poltekkes Kemenkes Bandung provides various facilities, including interactive classrooms, modern laboratories, a library, a network of partner hospitals, sports facilities, and student dormitories. These resources are designed to help students grow holistically.
As the director of Poltekkes Kemenkes Bandung, we remain firmly committed to upholding educational quality, driving innovation, and making tangible contributions to the advancement of national health. Through education, research, and community engagement, we are confident that Poltekkes Kemenkes Bandung will consistently produce generations of healthcare professionals who demonstrate integrity, excellence, and competitiveness at the global level.
With a clear vision and focused mission, Poltekkes Kemenkes Bandung is ready to produce professional, ethical, and highly dedicated healthcare professionals. Together, let's create a healthier Indonesia. Politeknik Kesehatan Kementerian Kesehatan Bandung, or Poltekkes Kemenkes Bandung, is a state vocational higher education institution under the Ministry of Health of the Republic of Indonesia. As a strategic center for health education, Poltekkes Kemenkes Bandung is dedicated to producing professional, ethical, and globally competitive healthcare professionals. Poltekkes Kemenkes Bandung is located at Jalan Pajajaran No. 56, Bandung City, West Java. Bandung is known as a cool and comfortable educational city. Our vision is to be a leading health polytechnic, excelling in applied technology, character development, and global competitiveness. This vision guides our every step as we grow and contribute to healthcare, both nationally and internationally. To achieve this vision, Poltekkes Bandung is committed to 7 core missions. First, provide high-quality education aligned with global orientation in applied health science and technology, producing graduates of strong character. Second, conduct innovative, applied technology-based research that leverages local resources and wisdom while empowering communities. Third, implement innovative community service initiatives that have a broad impact using research to strengthen quality education. Fourth, foster partnerships with national and international stakeholders for mutual progress. Fifth, develop new educational programs to meet the evolving demands of health science and technology. Sixth, cultivate an integrated and ethical workforce to ensure good and green governance, operating with transparency and accountability as a public service institution. 7. Lead health transformation by establishing a Center of Excellence for Diabetes Mellitus Education, integrated into our core academic activities of teaching, research, and community service. Poltekkes Bandung has the following human resources. Poltekkes Bandung offers a variety of academic programs designed to train competent healthcare professionals. Our departments include the Department of Nursing, the Diploma of Nursing program in Bogor, Department of Midwifery, the Diploma of Midwifery program in Bogor, the Diploma of Midwifery program in Karawang, the Department of Environmental Health, the Department of Pharmacy, the Department of Nutrition, the Department of Dental Health, the Department of Medical Laboratory Technology, and Department of Health Promotion. Those campuses are spread across several cities. Campus A is in Bandung. Campus B is in Cimahi. Campus C is in Karawang. And Campus D is in Bogor. Poltekkes Bandung achieved the highest 100% competency test pass rate in 2024 at the national level. Students and lecturers at Poltekkes Bandung not only excel in academics, but also actively excel in various activities, including research, student organizations, community service, and local, national, and international competitions. The numerous awards they have won prove their strong competitive spirit and ability to bring recognition to our institution. To support a comfortable and innovative learning environment, Poltekkes Bandung provides various facilities, including interactive classrooms, modern laboratories, a library, a network of partner hospitals, sports facilities, and student dormitories. These resources are designed to help students grow holistically.
As the director of Poltekkes Bandung, we remain firmly committed to upholding educational quality, driving innovation, and making tangible contributions to the advancement of national health. Through education, research, and community engagement, we are confident that Poltekkes Bandung will consistently produce generations of healthcare professionals who demonstrate integrity, excellence, and competitiveness at the global level.
With a clear vision and focused mission, Poltekkes Bandung is ready to produce professional, ethical, and highly dedicated healthcare professionals. Together, let's create a healthier Indonesia. Politeknik Kesehatan Kementerian Kesehatan Bandung, or Polkesban Bandung, is a state vocational higher education institution under the Ministry of Health of the Republic of Indonesia. As a strategic center for health education, Polkesban Bandung is dedicated to producing professional, ethical, and globally competitive healthcare professionals. Polkesban Bandung is located at Jalan Pajajaran number 56, Bandung City, West Java. Bandung is known as a cool and comfortable educational city. Our vision is to be a leading health polytechnic, excelling in applied technology, character development, and global competitiveness. This vision guides our every step as we grow and contribute to healthcare, both nationally and internationally. To achieve this vision, Polkesban Bandung is committed to 7 core missions. First, provide high-quality education aligned with global orientation in applied health science and technology, producing graduates of strong character. Second, conduct innovative applied technology-based research that leverages local resources and wisdom while empowering communities. Third, implement innovative community service initiatives that have a broad impact using research to strengthen quality education. Fourth, foster partnerships with national and international stakeholders for mutual progress. Fifth, develop new educational programs to meet the evolving demands of health science and technology. Sixth, cultivate an integrated and ethical workforce to ensure good and clean governance, operating with transparency and accountability as a public service institution. 7. Lead health transformation by establishing a Center of Excellence for Diabetes Mellitus Education, integrated into our core academic activities of teaching, research, and community service. Polkesban Bandung has the following human resources. Polkesban Bandung offers a variety of academic programs designed to train competent healthcare professionals. Our departments include the Department of Nursing, the Diploma of Nursing program in Bogor, Department of Midwifery, the Diploma of Midwifery program in Bogor, the Diploma of Midwifery program in Karawang, the Department of Environmental Health, the Department of Pharmacy, the Department of Nutrition, the Department of Dental Health, the Department of Medical Laboratory Technology, and Department of Health Promotion. Those campuses are spread across several cities. Campus A is in Bandung. Campus B is in Cimahi. Campus C is in Karawang. And Campus D is in Bogor. Polkesban Bandung achieved the highest 100% competency test pass rate in 2024 at the national level. Students and lecturers at Polkesban Bandung not only excel in academics, but also actively excel in various activities, including research, student organizations, community service, and local, national, and international competitions. The numerous awards they have won prove their strong competitive spirit and ability to bring recognition to our institution. To support a comfortable and innovative learning environment, Poltekkes Kemenkes Bandung provides various facilities, including interactive classrooms, modern laboratories, a library, a network of partner hospitals, sports facilities, and student dormitories. These resources are designed to help students grow holistically.
As the director of Poltekkes Kemenkes Bandung, we remain firmly committed to upholding educational quality, driving innovation, and making tangible contributions to the advancement of national health. Through education, research, and community engagement, we are confident that Poltekkes Kemenkes Bandung will consistently produce generations of healthcare professionals who demonstrate integrity, excellence, and competitiveness at the global level.
With a clear vision and focused mission, Poltekkes Kemenkes Bandung is ready to produce professional, ethical, and highly dedicated healthcare professionals. Together, let's create a healthier Indonesia. Politeknik Kesehatan Kementerian Kesehatan Bandung, or Poltekkes Kemenkes Bandung, is a state vocational higher education institution under the Ministry of Health of the Republic of Indonesia. As a strategic center for health education, Poltekkes Kemenkes Bandung is dedicated to producing professional, ethical, and globally competitive healthcare professionals. Poltekkes Kemenkes Bandung is located at Jalan Pajajaran number 56, Bandung City, West Java. Bandung is known as a cool and comfortable educational city. Our vision is to be a leading health polytechnic, excelling in applied technology, character development, and global competitiveness. This vision guides our every step as we grow and contribute to healthcare, both nationally and internationally. To achieve this vision, Poltekkes Kemenkes Bandung is committed to 7 core missions. First, provide high-quality education aligned with global orientation in applied health science and technology, producing graduates of strong character. Second, conduct innovative, applied technology-based research that leverages local resources and wisdom while empowering communities. Third, implement innovative community service initiatives that have a great impact using research to strengthen quality education. Fourth, foster partnerships with national and international stakeholders for mutual progress. Fifth, develop new educational programs to meet the evolving demands of health science and technology. Sixth, cultivate an integrated and ethical workforce to ensure good and green governance, operating with transparency and accountability as a public service institution. Seventh, lead health transformation by establishing a center of excellence for diabetes mellitus education, integrated into our core academic activities of teaching, research, and community service. Poltekkes Kemenkes Bandung has the following human resources. Poltekkes Kemenkes Bandung offers a variety of academic programs designed to train competent healthcare professionals. Our departments include the Department of Nursing, the Diploma of Nursing program in Bogor, Department of Midwifery, the Diploma of Midwifery program in Bogor, the Diploma of Midwifery program in Karawang, the Department of Environmental Health, the Department of Pharmacy, the Department of Nutrition, the Department of Dental Health, the Department of Medical Laboratory Technology, and Department of Health Promotion. Those campuses are spread across several cities. Campus A is in Bandung. Campus B is in Cimahi. Campus C is in Karawang. And Campus D is in Bogor. Poltekkes Kemenkes Bandung achieved the highest 100% competency test pass rate in 2024 at the national level. Students and lecturers at Poltekkes Kemenkes Bandung not only excel in academics, but also actively excel in various activities, including research, student organizations, community service, and local, national, and international competitions. The numerous awards they have won prove their strong competitive spirit and ability to bring recognition to our institution. To support a comfortable and innovative learning environment, Poltekkes Kemenkes Bandung provides various facilities, including interactive classrooms, modern laboratories, a library, a network of partner hospitals, sports facilities, and student dormitories. These resources are designed to help students grow holistically.
As the director of Poltekkes Kemenkes Bandung, we remain firmly committed to upholding educational quality, driving innovation, and making tangible contributions to the advancement of national health. Through education, research, and community engagement, we are confident that Poltekkes Kemenkes Bandung will consistently produce generations of healthcare professionals who demonstrate integrity, excellence, and competitiveness at the global level.
With a clear vision and focused mission, Poltekkes Kemenkes Bandung is ready to produce professional, ethical, and highly dedicated healthcare professionals. Together, let's create a healthier Indonesia. Politeknik Kesehatan Kementerian Kesehatan Bandung, or Poltekkes Kemenkes Bandung, is a state vocational higher education institution under the Ministry of Health of the Republic of Indonesia. As a strategic center for health education, Poltekkes Kemenkes Bandung is dedicated to producing professional, ethical, and globally competitive healthcare professionals. Poltekkes Kemenkes Bandung is located at Jalan Pajajaran number 56, Bandung City, West Java. Bandung is known as a cool and comfortable educational city. Our vision is to be a leading health polytechnic, excelling in applied technology, character development, and global competitiveness. This vision guides our every step as we grow and contribute to healthcare, both nationally and internationally. To achieve this vision, Poltekkes Kemenkes Bandung is committed to 7 core missions. First, provide high-quality education aligned with global orientation in applied health science and technology, producing graduates of strong character. Second, conduct innovative, applied technology-based research that leverages local resources and wisdom while empowering communities. Third, implement innovative community service initiatives that have a broad impact using research to strengthen quality education. Fourth, foster partnerships with national and international stakeholders for mutual progress. Fifth, develop new educational programs to meet the evolving demands of health science and technology. Sixth, cultivate an integrated and ethical workforce to ensure good and green governance, operating with transparency and accountability as a public service institution. 7. Lead health transformation by establishing a Center of Excellence for Diabetes Mellitus Education, integrated into our core academic activities of teaching, research, and community service. Poltekkes Kemenkes Bandung has the following human resources. Poltekkes Kemenkes Bandung offers a variety of academic programs designed to train competent healthcare professionals. Our departments include the Department of Nursing, the Diploma of Nursing program in Bogor, Department of Midwifery, the Diploma of Midwifery program in Bogor, the Diploma of Midwifery program in Karawang, the Department of Environmental Health, the Department of Pharmacy, the Department of Nutrition, the Department of Dental Health, the Department of Medical Laboratory Technology, and Department of Health Promotion. Those campuses are spread across several cities. Campus A is in Bandung. Campus B is in Cimahi. Campus C is in Karawang. And Campus D is in Bogor. Poltekkes Kemenkes Bandung achieved the highest 100% competency test pass rate in 2024 at the national level. Students and lecturers at Poltekkes Kemenkes Bandung not only excel in academics, but also actively excel in various activities, including research, student organizations, community service, and local, national, and international competitions. The numerous awards they have won prove their strong competitive spirit and ability to bring recognition to our institution. To support a comfortable and innovative learning environment, Poltekkes Kemenkes Bandung provides various facilities, including interactive classrooms, modern laboratories, a library, a network of partner hospitals, sports facilities, and student dormitories. These resources are designed to help students grow holistically.
As the director of Poltekkes Kemenkes Bandung, we remain firmly committed to upholding educational quality, driving innovation, and making tangible contributions to the advancement of national health. Through education, research, and community engagement, we are confident that Poltekkes Kemenkes Bandung will consistently produce generations of healthcare professionals who demonstrate integrity, excellence, and competitiveness at the global level.
With a clear vision and focused mission, Poltekkes Kemenkes Bandung is ready to produce professional, ethical, and highly dedicated healthcare professionals. Together, let's create a healthier Indonesia. Kesehatan Kementerian Kesehatan Bandung, or Poltekkes Kemenkes Bandung, is a state vocational higher education institution under the Ministry of Health of the Republic of Indonesia. As a strategic center for health education, Poltekkes Kemenkes Bandung is dedicated to producing professional, ethical, and globally competitive healthcare professionals. Poltekkes Kemenkes Bandung is located at Jalan Pajajaran number 56, Bandung City, West Java. Bandung is known as a cool and comfortable educational city. Our vision is to be a leading health polytechnic, excelling in applied technology, character development, and global competitiveness. This vision guides our every step as we grow and contribute to healthcare, both nationally and internationally. To achieve this vision, Poltekkes Kemenkes Bandung is committed to 7 core missions. First, provide high-quality education aligned with global orientation in applied health science and technology, producing graduates of strong character. Second, conduct innovative, applied technology-based research that leverages local resources and wisdom while empowering communities. Third, implement innovative community service initiatives that have a broad impact using research to strengthen quality education. Fourth, foster partnerships with national and international stakeholders for mutual progress. Fifth, develop new educational programs to meet the evolving demands of health science and technology. Sixth, cultivate an integrated and ethical workforce to ensure good and clean governance, operating with transparency and accountability as a public service institution. 7. Lead health transformation by establishing a center of excellence for diabetes mellitus education, integrated into our core academic activities of teaching, research, and community service. Poltekkes Kemenkes Bandung has the following human resources. Poltekkes Kemenkes Bandung offers a variety of academic programs designed to train competent healthcare professionals. Our departments include the Department of Nursing, the Diploma of Nursing program in Bogor, Department of Midwifery, the Diploma of Midwifery program in Bogor, the Diploma of Midwifery program in Karawang, the Department of Environmental Health, the Department of Pharmacy, the Department of Nutrition, the Department of Dental Health, the Department of Medical Laboratory Technology, and Department of Health Promotion. Those campuses are spread across several cities. Campus A is in Bandung. Campus B is in Cimahi. Campus C is in Karawang. And Campus D is in Bogor. Poltekkes Kemenkes Bandung achieved the highest 100% competency test rate in 2024 at the national level. Students and lecturers at Poltekkes Kemenkes Bandung not only excel in academics, but also actively excel in various activities, including research, student organizations, community service, and local, national, and international competitions. The numerous awards they have won prove their strong competitive spirit and ability to bring recognition to our institution. To support a comfortable and innovative learning environment, Poltekkes Kemenkes Bandung provides various facilities, including interactive classrooms, modern laboratories, a library, a network of partner hospitals, sports facilities, and student dormitories. These resources are designed to help students grow holistically.
As the director of Poltekkes Kemenkes Bandung, we remain firmly committed to upholding educational quality, driving innovation, and making tangible contributions to the advancement of national health. Through education, research, and community engagement, we are confident that Poltekkes Kemenkes Bandung will consistently produce generations of healthcare professionals who demonstrate integrity, excellence, and competitiveness at the global level.
With a clear vision and focused mission, Poltekkes Kemenkes Bandung is ready to produce professional, ethical, and highly dedicated healthcare professionals. Together, let's create a healthier Indonesia. Politeknik Kesehatan Kementerian Kesehatan Bandung, or Poltekkes Kemenkes Bandung, is a state vocational higher education institution under the Ministry of Health of the Republic of Indonesia. As a strategic center for health education, Poltekkes Kemenkes Bandung is dedicated to producing professional, ethical, and globally competitive healthcare professionals. Poltekkes Kemenkes Bandung is located at Jalan Pajajaran number 56, Bandung City, West Java. Bandung is known as a cool and comfortable educational city. Our vision is to be a leading health polytechnic, excelling in applied technology, character development, and global competitiveness. This vision guides our every step as we grow and contribute to healthcare, both nationally and internationally. To achieve this vision, Poltekkes Kemenkes Bandung is committed to 7 core missions. First, provide high-quality education aligned with global orientation in applied health science and technology, producing graduates of strong character. Second, conduct innovative applied technology-based research that leverages local resources and wisdom while empowering communities. Third, implement innovative community service initiatives that have a broad impact using research to strengthen quality education. Fourth, foster partnerships with national and international stakeholders for mutual progress. Fifth, develop new educational programs to meet the evolving demands of health science and technology. Sixth, cultivate an integrated and ethical workforce to ensure good and clean governance, operating with transparency and accountability as a public service institution. 7. Lead health transformation by establishing a center of excellence for diabetes mellitus education, integrated into our core academic activities of teaching, research, and community service. Poltekkes Kemenkes Bandung has the following human resources. Poltekkes Kemenkes Bandung offers a variety of academic programs designed to train competent healthcare professionals. Our departments include the Department of Nursing, the Diploma of Nursing program in Bogor, Department of Midwifery, the Diploma of Midwifery program in Bogor, the Diploma of Midwifery program in Karawang, the Department of Environmental Health, the Department of Pharmacy, the Department of Nutrition, the Department of Dental Health, the Department of Medical Laboratory Technology, and Department of Health Promotion. Those campuses are spread across several cities. Campus A is in Bandung. Campus B is in Cimahi. Campus C is in Karawang. And Campus D is in Bogor. Poltekkes Bandung achieved the highest 100% competency test pass rate in 2024 at the national level. Students and lecturers at Poltekkes Bandung not only excel in academics, but also actively excel in various activities, including research, student organizations, community service, and local, national, and international competitions. The numerous awards they have won prove their strong competitive spirit and ability to bring recognition to our institution. To support a comfortable and innovative learning environment, Poltekkes Bandung provides various facilities, including interactive classrooms, modern laboratories, a library, a network of partner hospitals, sports facilities, and student dormitories. These resources are designed to help students grow holistically.
As the director of Poltekkes Bandung, we remain firmly committed to upholding educational quality, driving innovation, and making tangible contributions to the advancement of national health. Through education, research, and community engagement, we are confident that Poltekkes Bandung will consistently produce generations of healthcare professionals who demonstrate integrity, excellence, and competitiveness at the global level.
With a clear vision and focused mission, Poltekkes Bandung is ready to produce professional, ethical, and highly dedicated healthcare professionals. Together, let's create a healthier Indonesia. Politeknik Kesehatan Kementerian Kesehatan Bandung, or Poltekkes Bandung, is a state vocational higher education institution under the Ministry of Health of the Republic of Indonesia. As a strategic center for health education, Poltekkes Bandung is dedicated to producing professional, ethical, and globally competitive healthcare professionals. Poltekkes Bandung is located at Jalan Pajajaran number 56, Bandung City, West Java. Bandung is known as a cool and comfortable educational city. Our vision is to be a leading health polytechnic, excelling in applied technology, character development, and global competitiveness. This vision guides our every step as we grow and contribute to healthcare, both nationally and internationally. To achieve this vision, Poltekkes Bandung is committed to 7 core missions. First, provide high-quality education aligned with global orientation in applied health science and technology, producing graduates of strong character. Second, conduct innovative, applied technology-based research that leverages local resources and wisdom while empowering communities. Third, implement innovative community service initiatives that have a broad impact using research to strengthen quality education. Fourth, foster partnerships with national and international stakeholders for mutual progress. Fifth, develop new educational programs to meet the evolving demands of health science and technology. 6. Cultivate an integrated and ethical workforce to ensure good and clean governance, operating with transparency and accountability as a public service institution. 7. Lead health transformation by establishing a center of excellence for diabetes mellitus education, integrated into our core academic activities of teaching, research, and community service. Poltekkes Kemenkes Bandung has the following human resources. Poltekkes Kemenkes Bandung offers a variety of academic programs designed to train competent healthcare professionals. Our departments include the Department of Nursing, the Diploma of Nursing program in Bogor, Department of Midwifery, the Diploma of Midwifery program in Bogor, the Diploma of Midwifery program in Karawang, the Department of Environmental Health, the Department of Pharmacy, the Department of Nutrition, the Department of Dental Health, the Department of Medical Laboratory Technology, and Department of Health Promotion. Those campuses are spread across several cities. Campus A is in Bandung. Campus B is in Cimahi. Campus C is in Karawang. And Campus D is in Bogor. Poltekkes Kemenkes Bandung achieved the highest 100% competency test rate in 2024 at the national level. Students and lecturers at Poltekkes Kemenkes Bandung not only excel in academics, but also actively excel in various activities, including research, student organizations, community service, and local, national, and international competitions. The numerous awards they have won prove their strong competitive spirit and ability to bring recognition to our institution. To support a comfortable and innovative learning environment, Poltekkes Kemenkes Bandung provides various facilities, including interactive classrooms, modern laboratories, a library, a network of partner hospitals, sports facilities, and student dormitories. These resources are designed to help students grow holistically.
As the director of Poltekkes Kemenkes Bandung, we remain firmly committed to upholding educational quality, driving innovation, and making tangible contributions to the advancement of national health. Through education, research, and community engagement, we are confident that Poltekkes Kemenkes Bandung will consistently produce generations of healthcare professionals who demonstrate integrity, excellence, and competitiveness at the global level.
With a clear vision and focused mission, Poltekkes Kemenkes Bandung is ready to produce professional, ethical, and highly dedicated healthcare professionals. Together, let's create a healthier Indonesia. Politeknik Kesehatan Kementerian Kesehatan Bandung, or Poltekkes Kemenkes Bandung, is a state vocational higher education institution under the Ministry of Health of the Republic of Indonesia. As a strategic center for health education, Poltekkes Kemenkes Bandung is dedicated to producing professional ethical, and globally competitive healthcare professionals. Poltekkes Kemenkes Bandung is located at Jalan Pajajaran number 56, Bandung City, West Java. Bandung is known as a cool and comfortable educational city. Our vision is to be a leading health polytechnic, excelling in applied technology, character development, and global competitiveness. This vision guides our every step as we grow and contribute to healthcare, both nationally and internationally. To achieve this vision, Poltekkes Kemenkes Bandung is committed to 7 core missions. First, provide high-quality education aligned with global orientation in applied health science and technology, producing graduates of strong character. Second, conduct innovative, applied technology-based research that leverages local resources and wisdom while empowering communities. Third, implement innovative community service initiatives that have a broad impact using research to strengthen quality education. Fourth, foster partnerships with national and international stakeholders for mutual progress. Fifth, develop new educational programs to meet the evolving demands of health science and technology. Sixth, cultivate an integrated and ethical workforce to ensure good and green governance, operating with transparency and accountability as a public service institution. 7. Lead health transformation by establishing a center of excellence for diabetes mellitus education, integrated into our core academic activities of teaching, research, and community service. Poltekkes Kemenkes Bandung has the following human resources. Poltekkes Kemenkes Bandung offers a variety of academic programs designed to train competent healthcare professionals. Our departments include the Department of Nursing, the Diploma of Nursing program in Bogor, Department of Midwifery, the Diploma of Midwifery program in Bogor, the Diploma of Midwifery program in Karawang, the Department of Environmental Health, the Department of Pharmacy, the Department of Nutrition, the Department of Dental Health, the Department of Medical Laboratory Technology, and Department of Health Promotion. Those campuses are spread across several cities. Campus A is in Bandung. Campus B is in Cimahi. Campus C is in Karawang. And Campus D is in Bogor. Poltekkes Kemenkes Bandung achieved the highest 100% competency test rate in 2024 at the national level. Students and lecturers at Poltekkes Kemenkes Bandung not only excel in academics, but also actively excel in various activities, including research, student organizations, community service, and local, national, and international competitions. The numerous awards they have won prove their strong competitive spirit and ability to bring recognition to our institution. To support a comfortable and innovative learning environment, Poltekkes Kemenkes Bandung provides various facilities, including interactive classrooms, modern laboratories, a library, a network of partner hospitals, sports facilities, and student dormitories. These resources are designed to help students grow holistically.
As the director of Poltekkes Kemenkes Bandung, We remain firmly committed to upholding educational quality, driving innovation, and making tangible contributions to the advancement of national health. Through education, research, and community engagement, we are confident that Poltekkes Kemenkes Bandung will consistently produce generations of healthcare professionals who demonstrate integrity, excellence, and competitiveness at the global level.
With a clear vision and focused mission, Poltekkes Kemenkes Bandung is ready to produce professional, ethical, and highly dedicated healthcare professionals. Together, let's create a healthier Indonesia. Politeknik Kesehatan Kementerian Kesehatan Bandung, or Poltekkes Kemenkes Bandung, is a state vocational higher education institution under the Ministry of Health of the Republic of Indonesia. As a strategic center for health education, Poltekkes Kemenkes Bandung is dedicated to producing professional, ethical, and globally competitive healthcare professionals. Poltekkes Kemenkes Bandung is located at Jalan Pajajaran number 56, Bandung City, West Java. Bandung is known as a cool and comfortable educational city. Our vision is to be a leading health polytechnic, excelling in applied technology, character development, and global competitiveness. This vision guides our every step as we grow and contribute to healthcare, both nationally and internationally. To achieve this vision, Poltekkes Kemenkes Bandung is committed to 7 core missions. First, provide high-quality education aligned with global orientation in applied health science and technology, producing graduates of strong character. Second, conduct innovative, applied technology-based research that leverages local resources and wisdom while empowering communities. Third, implement innovative community service initiatives that have a broad impact using research to strengthen quality education. Fourth, foster partnerships with national and international stakeholders for mutual progress. Fifth, develop new educational programs to meet the evolving demands of health science and technology. Sixth, cultivate an integrated and ethical workforce to ensure good and green governance, operating with transparency and accountability as a public service institution. 7. Lead health transformation by establishing a center of excellence for diabetes mellitus education, integrated into our core academic activities of teaching, research, and community service. Poltekkes Kemenkes Bandung has the following human resources. Poltekkes Kemenkes Bandung offers a variety of academic programs designed to train competent healthcare professionals. Our departments include the Department of Nursing, the Diploma of Nursing program in Bogor, Department of Midwifery, the Diploma of Midwifery program in Bogor, the Diploma of Midwifery program in Karawang, the Department of Environmental Health, the Department of Pharmacy, the Department of Nutrition, the Department of Dental Health, the Department of Medical Laboratory Technology, and Department of Health Promotion. Those campuses are spread across several cities. Campus A is in Bandung. Campus B is in Cimahi. Campus C is in Karawang. And Campus D is in Bogor. Poltekkes Bandung achieved the highest 100% competency test rate in 2024 at the national level. Students and lecturers at Poltekkes Bandung not only excel in academics, but also actively excel in various activities, including research, student organizations, community service, and local, national, and international competitions. The numerous awards they have won prove their strong competitive spirit and ability to bring recognition to our institution. To support a comfortable and innovative learning environment, Poltekkes Bandung provides various facilities, including interactive classrooms, modern laboratories, a library, a network of partner hospitals, sports facilities, and student dormitories. These resources are designed to help students grow holistically.
As the director of Poltekkes Bandung, we remain firmly committed to upholding educational quality, driving innovation, and making tangible contributions to the advancement of national health. Through education, research, and community engagement, we are confident that Poltekkes Bandung will consistently produce generations of healthcare professionals who demonstrate integrity, excellence, and competitiveness at the global level.
With a clear vision and focused mission, Poltekkes Bandung is ready to produce professional, ethical, and highly dedicated healthcare professionals. Together, let's create a healthier Indonesia. Politeknik Kesehatan Kementerian Kesehatan Bandung, or Poltekkes Bandung, is a state vocational higher education institution under the Ministry of Health of the Republic of Indonesia. As a strategic center for health education, Poltekkes Bandung is dedicated to producing professional, ethical, and globally competitive healthcare professionals. Poltekkes Bandung is located at Jalan Pajajaran number 56, Bandung City, West Java. Bandung is known as a cool and comfortable educational city. Our vision is to be a leading health polytechnic, excelling in applied technology, character development, and global competitiveness. This vision guides our every step as we grow and contribute to healthcare, both nationally and internationally. To achieve this vision, Poltekkes Bandung is committed to 7 core missions. First, provide high-quality education aligned with global orientation in applied health science and technology, producing graduates of strong character. Second, conduct innovative, applied technology-based research that leverages local resources and wisdom while empowering communities. Third, implement innovative community service initiatives that have a broad impact using research to strengthen quality education. Fourth, foster partnerships with national and international stakeholders for mutual progress. Fifth, develop new educational programs to meet the evolving demands of health science and technology. Sixth, cultivate an integrated and ethical workforce to ensure good and clean governance, operating with transparency and accountability as a public service institution. 7. Lead health transformation by establishing a center of excellence for diabetes mellitus education, integrated into our core academic activities of teaching, research, and community service. Poltekkes Kemenkes Bandung has the following human resources. Poltekkes Kemenkes Bandung offers a variety of academic programs designed to train competent healthcare professionals. Our departments include the Department of Nursing, the Diploma of Nursing program in Bogor, Department of Midwifery, the Diploma of Midwifery program in Bogor, the Diploma of Midwifery program in Karawang, the Department of Environmental Health, the Department of Pharmacy, the Department of Nutrition, the Department of Dental Health, the Department of Medical Laboratory Technology, and Department of Health Promotion. Those campuses are spread across several cities. Campus A is in Bandung. Campus B is in Cimahi. Campus C is in Karawang. And Campus D is in Bogor. Poltekkes Kemenkes Bandung achieved the highest 100% competency test rate in 2024 at the national level. Students and lecturers at Poltekkes Kemenkes Bandung not only excel in academics, but also actively excel in various activities, including research, student organizations, community service, and local, national, and international competitions. The numerous awards they have won prove their strong competitive spirit and ability to bring recognition to our institution. To support a comfortable and innovative learning environment, Poltekkes Kemenkes Bandung provides various facilities, including interactive classrooms, modern laboratories, a library, a network of partner hospitals, sports facilities, and student dormitories. These resources are designed to help students grow holistically.
As the director of Poltekkes Kemenkes Bandung, we remain firmly committed to upholding educational quality, driving innovation, and making tangible contributions to the advancement of national health. Through education, research, and community engagement, we are confident that Poltekkes Kemenkes Bandung will consistently produce generations of healthcare professionals who demonstrate integrity.
Excellencies, distinguished guests, participants, ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh. Peace be upon you. Welcome once again to the 8th International Conference, Interprofessional Collaboration and Community Empowerment. It is very nice to see you, all of you once again, and we hope you have been enjoying yourself up at the conference so far. Excellencies, distinguished guests, participants, ladies and gentlemen, I believe that we have had productive, inspiring time together. Now we will continue of today's event. Now I am excited to introduce the next segment of our webinar. Our next speaker will be sharing insight on interprofessional synergy in type 2 diabetes management. A Southeast Asian perspective, strengthening health resilience through community-based diabetes intervention, integrating faith-based and community engagement strategies in diabetes mellitus type 2 prevention. Listen from Malaysia. I know this is going to be incredible valuable for all of us. For the next session will be moderated by Mr. Paizar Wahyudi, SCAP MPH. He is currently a lecturer from Health Environment Department, Poltekkes Kemenkes Bandung. Please let's give a virtual round of applause for Mr. Paizar Wahyudi, SCAP MPH.
Assalamualaikum warahmatullahi wabarakatuh. Thank you so much, Mrs. Sumirta, for introducing me in such a great way. Good afternoon, ladies and gentlemen. Welcome back again to our virtual conference. This is the International Conference on Interprofessional Health Collaboration and Community Empowerment in 2025. This is the 8th edition, and the theme is about building global health resilience through interprofessional collaboration, sustainable solutions empowerment. Hello, my name is Paizar Wahidi. I'm one of the lecturers in Poltekkes Bandung, and wait a second, we got some situation here. Halo Mbak, gimana? Halo, cek.
Ya, terdengar Pak.
Okay. Thank you. Wait, let me restart again. Good afternoon, ladies and gentlemen. Welcome back to our virtual conference. This is the International Conference on Interprofessional Health Collaboration and Community Empowerment in 2025. This is the 8th edition, and the theme is about building global health resilience through interprofessional collaboration, sustainable solution in type 2 diabetes care and community empowerment. Hello, my name is Paizar Wahidi, a lecturer in Poltekkes Bandung. Afternoon session, I would like to thank you very much for all participants who have been joining us on this virtual conference from this morning. Right. On this session, we also have three excellent speakers who will deliver their presentation, and each speaker have 45 minutes to present. For your information, the presentation will run like a panel setting, which all speakers will present right through all at once, and we put Q&A section after the third speaker. Throughout the seminar, we encourage you to take notes and hold on to any questions you might have until the end. We'll aim to answer as many as questions possible during allocated Q&A times. Ladies and gentlemen, well, for the first speaker, we have an amazing person. He is a professor from Erlangga University, Surabaya. It's such a great opportunity to have him here with us to share insight, knowledge, and experience. But before that, let me read you a brief introduction about our first speaker on this afternoon. His name is Professor Dr. Ferry Effendi, PhD from Universitas Erlangga, Indonesia. Mr. Ferry is a professor in the Department of Community Health Nursing at Faculty of Nursing, Erlangga University, Surabaya, Indonesia. He is an active member of Association of Community Health Nursing Educator, or ACHNE, based on Dayton. His PhD in Community Health Nursing focuses on Indonesian migrant nurses, addressing challenges such as ethical recruitment, fair labor. Also collaborated with Indonesia's Ministry of Health and developed Pasar Kerja Perawat, an Android-based application with over 8,000 users from Indonesia and abroad. In addition, he also had been involved in various projects within the area of human resources for health at Ministry of Health of Indonesia. His research interests include health policy, community health, maternal and child health, and nurse migrations. Professor Ferry has been recognized as one of the top 2% of world scientists in the nursing field for 4 consecutive years, from 2022 until 2025, by Elsevier and Stanford University. Amazing. Recently, Professor Ferry was honored as an academic leader 2024 by the Ministry of Education of Indonesia in recognition of his outstanding contribution to education and research. Ladies and gentlemen, the topic that about to be presented by Professor Ferry is interprofessional synergy in type 2 diabetes management. It's a retrospective research from South Asian. Let me say hello to Professor Ferry. Hello, Prof.
Halo Kak Faizat Wahyudi.
Okay, it seems Professor Ferry is already joined us. Well, all right, without further ado, please, will please join me to welcoming Professor Dr. Ferry Effendi, PhD. Well, professors, the screen is yours.
Ya, thank you so much Kak Faizat Wahyudi. Assalamualaikum warahmatullahi wabarakatuh. Yeah, good afternoon, ladies and gentlemen, Excellency, for the organizer, especially the Poltekkes Kemenkes Bandung, and all of the teams, and of course, thank you so much to the uh, Excellency of Ministry of Health, and all of the international partners, and all of the speakers, at this special session, especially when we put ahead the topic on the sustainable solution in type 2 diabetes mellitus care and community empowerment. So let me share my screen. Yeah, hello, can you see my slide?
Yeah. Okay,
Yeah.
it's already seen.
Yeah, okay. Yeah, thank you so much. So I'm really keen to talk about the interprofessional synergy in type 2 diabetes management, yeah, especially from the Southeast Asian perspective, yeah. And yeah, from my presentation, yeah, maybe I would like to highlight some experiences that I had, yeah, when we delivered the nursing services, especially in the community level. So yeah, because my expertise is in community health nursing, yeah. So maybe some of my experience, yeah, regarding on how to deliver and also how to caring the people with community, with diabetes mellitus, yeah, especially in the community level, yeah, that should be treated not only in short but also in long-term caring plan, yeah. And this is also our challenge, how to give the best quality nursing services, yeah, especially when we talk about the clinical services, yeah, at the hospital, or after they have treated in the hospital and they goes to the community and also the family level. Yeah. So my uh, talks today, I would like to discuss about the basic concept of interprofessional collaboration. Yeah, especially when we are dealing the non-communicable disease. And then the second is how to engage a patient, yeah, especially in decision making. Yeah, and then lastly, I will try to talk about the communication strategies, yeah, especially in interprofessional communication things. Yeah. So this is the big picture in our uh, global context. Yeah, as we have seen that 1 in 9 people are living with diabetes. Yeah, and we can see that actually from this data, yeah, the International Diabetes Federation mentioned that there are a lot of initiative, a lot of program, yeah, a lot of projects should be done, yeah, to solve and also to decrease the prevalence of diabetes mellitus, yeah. And 3 key points, yeah, that should be being a national priority, yeah. First is talking about the advocacy, yeah. The advocacy is it means that all of the activities or all of the initiative, yeah, should be coordinated, yeah, at the global level and also at the national level through every stakeholders that engage in non-communicable disease program. And then the second is talking about awareness, yeah. So awareness, actually the IDF and also the members and stakeholders, yeah, uh, having an ultimate goals, yeah, to keep diabetes firmly in the public spotlight, yeah, and also to promote the importance of coordinated and also the concerted action to tackle the impact of the condition. And then the last thing is talking about education. So the education initiative, yeah, aim to support the development of health personnel, yeah, and improve understanding of the condition among people living with diabetes. Yeah. So talking about these 3 pillars, yeah, actually a lot of challenges, yeah, should be addressed not only in terms of the capacity of the health workers, yeah, but also the capacity in the population level. And yeah, based on the recent data by IDF, yeah, actually Indonesia is having one of the highest prevalence, yeah, of diabetes in the world. Yeah. As we can see that in Indonesia itself, yeah, based on the data in 2024, yeah, we have a total population of 185 million of population, and from this number, yeah, actually we have around 11.3%, yeah, of Indonesian having diabetes, yeah, among adult people, yeah. So it means that, yeah, still around 18 million, yeah, 18 million of Indonesian, yeah, having this disease right now, yeah. And then, yeah, the total cases is really staggering, yeah, and also as we can see that the number is actually reaching out 20 million, yeah, of the total adults, yeah, having diabetes mellitus, yeah. So why we should taking care the IPC, yeah, the interprofessional collaboration, yeah, as we can see that based on the diabetes prevalence, yeah, 20 million, yeah, this is a huge number, this is a abundant number, and yeah, we cannot solve this number by Superman, yeah. So it is not only dealing with one person, yeah, but also we have we should compile all of the energy, all of the commitment, yeah, of the super team, yeah, to handle this problem. And there are some reasoning that we should taking care, yeah, when we are dealing with the IPC. First is diabetes is multifactorial, yeah. So this is not only the domain of medical, but also related to behavioral, yeah, nutritional, psychosocial, and yeah, another dimension that really related to the social determinant of health. Yeah. So when we are having the point of view of NCD or point of view of diabetes mellitus, yeah, actually a lot of factors, yeah, also related to the prevalence of diabetes mellitus. Yeah, let's say when we have a chit chat with our friend, yeah, and then we choose to drink a sweet soup, a sweet drink, yeah, or maybe a very sweet snack, yeah, very sweet food, yeah, that really impacting the metabolism in our body, yeah, by responding to increase the number of insulin, yeah. So this is also very complex and related to the behavioral aspect. And then the second is, as we can see from previous studies, yeah, the IPC, yeah, actually can improve the glycemic control, yeah, by lowering the HbA1c, yeah, and then it's also improve the patient satisfaction and adherence, yeah, and the third is it is reduce the hospitalization and cost, yeah, and then in IPC, actually the core principle is having the similarity, yeah, having the same value as the value of Indonesian people, yeah, sharing goal, yeah, gotong royong, yeah, mutual respect, yeah, and also complementary expertise, yeah. So what is actually the IPC model, yeah? I took some data from the Scopus AI, yeah, and then trying to understand what kind of studies, what kind of available evidence, yeah, related to the IPC itself, yeah. So in concept, yeah, in general, yeah, the IPC could be divided into three domain, yeah. First is professional practice, second is patient care, and the third is talking about teamwork, yeah. So from the professional practice, yeah, actually, yeah, we should address the concern about public relation. Yeah, we should also address the leadership. Yeah, it's related to the organizational culture and also the interprofessional relation. And from the domain of patient care, yeah, we can see that there are personalized care and also the quality of care that should be taken into account, yeah, when we are dealing with the IPC, yeah. And then the last one is about teamwork, yeah, teamwork. Uh, the team itself, yeah, I mentioned about super team, yeah, building a super team, yeah, building the spirit of togetherness, yeah, belongingness, yeah. So it's actually should be initiated with the team training, yeah. So we have to give education and also the counseling, yeah, about how to set up a good team, yeah, and how to coordinate with another individual that having a different responsibility and authority. And then the second one is talking about cooperative behavior. Yeah. So as we can see that actually the IPC, yeah, the IPC itself, yeah, it is involved of a different domain. Yeah, and this is really essential to delivering personalized care. Yeah. So we can see what is the needs of the individual. Yeah, and how we as health workers, we as a health medicine, yeah, really answer the need of the individual or the patient, yeah. And what are the available evidence regarding the IPC in diabetes management? We can see that the first is that should be community engagement. So why we need community engagement? Not only in the level of population but also in groups, family, and also in individual. Because actually the engagement itself, it is aim to improve the quality of life and also the primary care. And we do understand that the primary care in Indonesia is having a big transformation. We now planning, we now executing the ILP, integrasi layanan primer. So by doing the primary services integration, in all aspect of primary care, actually we need to simplify it, we need to integrate it, and also we need to make all of the care services coordinated into one unit on one vision and mission. And then the second is addressing the education and training. This is related to the feedback system and also the interprofessional education. Actually delivering the IPC in the non-communicable diseases should be started from the production sector, from the educational sector. That's why some of the curriculum also adjusted to facilitate the interprofessional education. And then the third is talking about patient outcome. This is also related to the patient reported outcomes, blood pressure regulation, and also the hemoglobin A1C control. And this is really important when we want to see what is the outcome of our nursing care or nursing services. And then the last one is role of healthcare professional. So it's depend on certain types of health workers, whether it should be treated on diabetes team. It means the team consisting of medical doctor, nurses, and any other types of health workers, or this is really related to the pharmacists, to the medicine, and also related to the nurses itself, as one of the backbone of the health system. So I'm reading one. Sorry, I think the voice is noisy. The organizer, could you please mute the noisy voices?
For the committee,
Hello.
we
Can you please mute
another sound here? Maybe can
some noisy? Yeah. Okay. So
Okay.
Next is I want to tell you one of the case study that happening in the community level, or family level, that we've been treated well, and also we can see that actually each case, or several cases that happen in the community and family level also should be coordinated not only by nurses, but also with another health human resources for health. So let's say when we are having a home visit to the one of the family in our neighborhood, we found one client with age 55. He's a public transport driver, and also he's living in crowded Surabaya suburb, and his education is junior higher education and also having unstable income. He falls into the lower middle socioeconomic group. And he has had type 2 diabetes mellitus for 6 years, with obesity, with BMI on 130, and long history of heavy smoker and dental caries. And of course, his unhealthy lifestyle includes frequent fast food, and his blood sugar is poorly controlled. As we can see, some indicators is actually worse. And he often skip medication when asymptomatic. It's high carbohydrate, low fiber meals, and skip breakfast. And of course, another point is physical activity is minimal, due to long hours sitting, and he live with his grandchild who is exposed to indoor smoke. Yeah, family support is weak. His wife is uninvolved, and he rarely visit the puskesmas. Yeah, citing long waits and lack of time. So this is the real case that we found in the community and family level. Yeah, and by doing by seeing this case, yeah, actually the problem of diabetes mellitus type 2, yeah, it's really complicated. Yeah, it's really problematic. Yeah, when we are having an issue of social determinant of health. Yeah, so it means that when we are dealing with the low educational level, yeah, also unstable income, yeah, and then some comorbidities, yeah, that also arise from one client, one patient, yeah, we have to have a strategy, yeah, how to handle this, yeah, and then how to manage this disease, yeah, to talk with another health professional, yeah. So by doing or by having the team-based structure, yeah, not only involving the patient but also another health workers, yeah, let's say dentists, yeah, nutritionists, yeah, pharmacists, yeah, and then specialists, yeah, support staff, yeah. Actually, we can make transformation in the person or people life. Yeah, we can make some positive behaviors. Yeah, that should be not only things in a short period, but also it should be sustained. Yeah, for a longer period. Yeah, and yeah, it should be done in the team-based structure. Yeah, so. There are some models of interprofessional collaboration in diabetes management, especially in the global context, yeah, such as ASEAN region, yeah, as we can see, the setting really define, yeah, really determine, yeah, how is the key professional and also the core activities and evidence of benefit that happen to be known at this time. Yeah. So first is with the hospital-based clinic setting. Yes, actually the key professional. Yeah, this is the three essential health workers. Yeah, with the core activities is joint consultation or medication review, and from the data it is improved the some indicators of clinical blood marker, and then. The second is in the community or primary care. Yeah, we can see that the key professional is actually nurses and also the community health workers. Yeah, with nutritionist, yeah, and the core activities is by doing home visits, healthcare, and also sustain and continuous frequent education. And then the last one is student-led clinics, yeah, when we are working with the student, yeah, and we can see here the key professional is actually the interprofessional student, and the core activities is experiential learning and also the patient coaching. And what are the benefits of interprofessional synergy? The first is improve the clinical outcome by seeing the reduction of HbA1c, improve lipid and blood pressure control. And then the second is psychosocial outcome, yeah, like improving the self-efficacy and also decreasing the distress. And then improving the system outcomes, yeah, by lowering the readmission rate, yeah, among the patient with type 2 diabetes mellitus, and reducing costs and also increase the continuity of care. And then the last is educational gains. Yeah, this is addressing the interprofessional education built for future workforce capacity. So yeah, one of the critical point, yeah, in interprofessional collaboration synergy, yeah, on delivery, yeah, among people with type 2 diabetes mellitus is actually how to engage patient in self decision making and also the goal setting. Yeah, because the decision making, yeah, should be addressed and also should be agreed among stakeholders, and also defining the goals. Yeah, what are the ultimate goals? Yeah, what should be done in 3 months, 5 months ahead, or even in 1 or 2 years ago. Yeah, so this is really crucial. Yeah. And yeah, we can see that actually the empowerment through goal setting, yeah, this is should be agreed by the parties, yeah, not only the client, the patient, yeah, but also the health workforce, yeah. So setting achievable goals, yeah, empower patient in managing their health effectively and also confidently, yeah. So it means that the goals itself, yeah, should be smart, should be measurable, yeah, should be achievable and having a timely a clear, timely goals. Yeah, so this is one key point of the empowerment through goals. And then the second, it should be discussed. Yeah, it should be disseminated, and also it should be taught to another healthcare workers. Yeah, so maybe we should talk to the nutritionist. We should talk to doctor. Yeah, we should talk to another type of health workers. And then the third is what are our main goals? Yeah, is actually improving the quality of life. Yeah, and also achieving the health outcome. Yeah, so we can see that working towards health goals leads to improve health outcome and also the patient satisfaction. Yeah. So yeah, self-management in chronic illnesses, yeah, like type 2 diabetes mellitus is important, yeah, because if they don't have good or positive self-management, yeah, actually the regime, yeah, the behavioral changes itself, yeah, it is not sustained, and also the patient could be back to the first situation or condition, yeah. So it is really important on how to empower the patient, yeah, to take control of their health, yeah. That's the first point. And then the second is we have to educate patient, yeah, about the chronicity of the non-communicable disease, especially the type 2 diabetes mellitus, yeah, because this is a chronic disease, yeah, a long period, yeah, a long situation that only the patient, yeah, could manage and also could control the progressivity, yeah, of the disease, yeah. And then the third is informed choices, yeah. So the informed choices related to diet, yeah, and then exercise, and also the medication improve, yeah. This is the basic that should be taught to the patient or to the family. So how to engage or involve the active participation in decision making? Yeah, of course, the first is goal setting discussion. Yeah, patient collaborate with provider to define realistic and also personalized health goals. Yeah, whether this is my need. Yeah, whether this is my milestone. Yeah, this is my achievement. Yeah, that should be discussed in the goal setting. And then the second is exploring preferences. Yeah, provider ask about dietary habit, yeah, activity level, and also cultural belief to guide planning. And then the third is shared decision-making tools. Yeah, we can use visual aids, charts, or apps that help patient with option. And then the fourth is negotiation and flexibility. This is plan adapted based on what patient feel, yeah, and that most likely to be achieved, yeah. And then ongoing feedback loop, yeah, it should be delivered, yeah, should be done, especially on patients like progress and adjust goals in follow-up visit. And then the last one is coaching and education, yeah. So this is talking about provided support patient, yeah, with information and skill to carry out their choices effectively. And yeah, how to improve outcome and also patient satisfaction? Yeah, first we have to ensure that the patient engaged, yeah, the patient respected, yeah, the patient involved, yeah, in every step of decision making, and also they have active participation, yeah, in the behavioral changes, yeah. And then the second, we have to also addressing the health outcome improvement. So based on the studies indicate that patient involvement is correlated with significant improvement in health outcome. And then overall, yeah, increased patient involvement contribute to heightened overall satisfaction with healthcare services. Yeah, so this is the 3 points that should be addressed. Yeah. So what are strategies for effective communication between the IPC team and the patient? Yeah. First is building trust and rapport. Yeah, this is important to see that, yeah, when we communicate, when we talk to the patient, yeah, or when we develop therapeutic communication, yeah, it should be based on trust. Yeah, the trust not only coming from the patient but also coming from the another health workers. Yeah, and then the second is empathy. Yeah, so empathy allow healthcare providers, yeah, to connect with patient, yeah, making them feel valued and also making them understood, yeah. And then the last one is yeah, keep listening, yeah, because somehow people are really like to talk, yeah, rather than listening, yeah. But active listening is actually crucial, yeah, for understanding patient needs and concern, yeah, and also enhancing the patient experience, yeah. And then talking about the communication, yeah, actually we have also to establish the clear and accessible communication. Yeah, it means that clear language help patient uh, 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 get the message, yeah, grab the complex medical information, and also make them more informed about their health, and also using plain language and visual aids, yeah, to explain treatment plans, medication instruction, and also lifestyle changes. And then the second is retention of information. Yeah, it is also need to be strategized. Yeah, when we are dealing with the various level of education of the patient, and yeah, we can improve the retention by providing memorable representation of that information, including aiding the patient recall. Yeah. And then the last one is informed decision making. Yeah, patient who understand that get option can make informed decision about their treatment and also the health management. And what are the strategic recommendation? Yeah, at the policy, system, education, and also the technology level. First is from policy level. In terms of the policy level, it should be institutionalized, yeah. It should be integrated, yeah, PC framework into national diabetes program, yeah. Maybe in our countries, we have a Prolanis program, yeah, that integrated in the primary level and also in the BPJS program, yeah. So it could be done by developing or creating a positive policy level. And then the second is incentivized discount model. Then the second is system level. Yeah, this should be established multidisciplinary clinic, also send electronic health record platform, and also schedule routine interprofessional case conferences. The third is education level. Yeah, this is embed in the professional education in undergraduate curricula and also continuous professional development for practicing clinician. And then the last one is use telemedicine and also digital platform to enhance coordination and follow-up. And what are the future direction and research gap? Yeah, we can see that we need to conduct certain priority, yeah, in our research agenda, especially first is evaluate the cost effectiveness of IPC in low resource setting, especially in Southeast Asia. And then the second is examine cultural determinant of teamwork and role perception. And the third is develop region-specific IPC competency framework. Yeah. And encouraging patient feedback and cultural sensitivity are also essential, yeah, especially on the long-term impact, long-term outcome. Yeah, first is we have to keep patient talking about their satisfaction, yeah, talking about their expectation, and talking about what their need in the point of view of the patient or client. Yeah. So encouraging patient feedback is essential, yeah, to enhance the quality. And then the second is cultural sensitivity in caring. Yeah, it's also should be immersed, yeah, the healthcare providers, yeah, characters, yeah, and also understand the diverse patient background because we can see that, yeah, 20 million of prevalence number of the dealt with diabetes mellitus actually coming from diverse background, yeah, different ethnicity and also different level of socioeconomic, yeah. And then the third is personalized care approaches, yeah, by integrating patient feedback and also understanding their value, their culture, yeah. Care can be tailored to meet individual patient preferences and also the need, yeah. So this is the last slide from my presentation. Yeah, what are the conclusions of the IPC model in type 2 diabetes mellitus? Yeah, actually, there are a lot of advantages. Yeah, there are a lot of positive outlook. Yeah, need to be considered. Yeah, first is interprofessional synergy is pivotal to achieving effective patient-centered diabetes care in Southeast Asia. And then the second is strengthening collaboration across discipline addresses both clinical and systemic gaps. And then the third is from continuation to co-creation, yeah, toward sustainable diabetes management aligned with especially the Sustainable Development Goals target 3. So in conclusion, implementing patient-centered care and also the interprofessional collaboration model offers numerous advantages, including improved health outcome, stronger patient-provider relationship, and enhanced patient satisfaction in managing chronic condition. So this is the last slide from me. So again, we need to unite as a health professional. And also we need to listen. We need to understand each other, and we have to work together with another type of health professional. These are my references. So that's all from me. Thank you so much. I'm giving over to moderator. So thank you again. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Sorry for the inconvenience because it's rain outside. Thank you very much, Professor Ferry Effendi, for your insightful presentation. That was incredible. Yep. International interprofessional collaboration provides the team structure, communication, and organizational culture that enable practical and consistent implementation of IPC principle itself. Okay, I'm pretty sure our audience learned a lot from you today, Prof. And I beg your time to keep staying with us here since we have Q&A session after the third speaker. And for all participants, we encourage you to type your question that you might have on chat box and hold on to until we arrive on the last speaker. And we remind you to keep your audios off, please. Once again, thank you very much, Professor Effendi. All right, ladies and gentlemen, for the time being, we'll move on to the second speaker who came from Finland. Of course, it's going to be very interesting because we'll get different perspective since our speakers came from developed country. Our second speaker is Miss Thea Furela, PhD from Tampere University, Finland. Her last education is diabetology at University of Tampere, and now she works as diabetes care specialist at Pirkanmaa Wellbeing County Tampere, and also as a family doctor at Pirkanmaa Wellbeing Service County Tampere. So she is a specialist practitioner of diabetes. Well, ladies and gentlemen, Mrs. Thea Furela will deliver the presentation through a video that had been recorded before, titled Strengthening Health Resilience Through Community-Based Diabetes Interventions. But don't worry, Mrs. Thea will join us immediately on Q&A sessions. All right, the committee or operator will share the video soon. We kindly remind all participants to watch, enjoy, and type your question on the chat box if you have a specific question to the specific speaker. Okay, the video is already on the screen share.
Hello.
Yeah.
And greetings from Finland.
Miss...
My name is Thea Vuorela, and my subject today is strengthening health resilience through community-based diabetes intervention, or how diabetes care is organized in Finland. I'm very happy and honored to be part of this seminar, and I'm excited about my subject. First, I want to tell a few words about myself. I'm a medical doctor. I graduated from our local medical school, University of Tampere, in 2012 and have been practicing medicine ever since. My specialty is general practice or in some countries it's more known as family doctor. And I got my specialization ready in 2024. In Finland, medical school takes 6 years, and after that you can choose a specialty where you will specialize in. And my specialty, general practice, it takes as long time to specialize as, for example, in cardiology or surgery. So my specialty is similar to any other. I work in public healthcare, which means it's a government-funded healthcare center. It's not private, but it's public. And my work in there, it includes work in a healthcare center, which means that my patients are anybody from babies to grandparents, so to say, and their problems can be anything. And if there is something I can't take care of or I don't have enough specialty in, I might refer them to the hospital or some specialist clinic. And 1 day a week I work in public diabetes clinic, and there we treat mostly type 1 diabetes patients. Let's get back to type 1 and type 2 diabetes a little bit later. I'm in process of getting my sub-specialty in diabetes care. If you work daily in diabetes clinic, it takes 2 years to get this sub-specialty, but since I only work 1 day a week, it of course takes a longer time. And I am married. I'm mother of 5 children, and currently I'm in maternity leave. So right now I'm not working as a doctor, but I will be getting back to my medicine career in about 3 months. Then I want to say a few words about Finland. This is a map of Europe, and Finland is marked as blue, so you can see that my country is situated in northern Finland, in northern Europe. Our neighboring countries are Sweden and Russia. And we are quite a small country, population of only 5.6 million people. And even though we are next to big country Russia, we are not a Slavic country. We are more like Western country, Western democracy, which means that, for example, the laws are passed by our. There is election every 4 years, and the parliament is elected, and they pass the laws. We have president, but president is more like moral, or they don't have as much power as parliament that has been elected democratically. And Finland is ranked 3rd highest quality of life out of 170 countries, which measures, for example, how people's basic needs are met, how much there is well-being, and how the environmental quality has been subjected. So I think that tells quite well that Finland is a good place to live and a good place to work as well. And I also wanted to bring the subject of taxation, because later on I will be talking how care is funded, where the money comes from, how to treat diabetes, and there I might say that this is paid with taxpayers' money, or this is public funding. And yes, our taxes are quite high. We have progressive taxation, which means that the more you earn from your work, the more you pay taxes, the higher the percentage is. So, for example, if you are in a job that pays little, you only pay little, maybe 10% of your income as taxes. But if you are working in some job where you earn quite a high salary, it might be even up to 50% your taxes. But average is 20%. I think that's what I wanted to tell about Finland, as if what is relevant about our subject today. Then, today's subject is diabetes. So I want to say a few general words about diabetes in Finland and then go back to our healthcare system. So when you mention diabetes or sugar disease here, all the health professionals know what the definition is, what it means that the person has diabetes. And here the definition is that you have had in a laboratory your blood glucose level measured, and it has been more than 7 millimoles per liter, which we use, or 126 milligrams per deciliter, that I believe is used in other countries as unit. And this level of diabetes is relevant after fasting. So if you haven't eaten anything for 10 to 12 hours and your blood glucose level is 126 or more, that counts as diabetic level. Or if after meal your blood glucose level is more than, in our unit, 11 millimoles per liter or 198 milligrams per deciliter. And you have to have 2 abnormal values on at least 2 different days. Or if the diagnosis is made not with these simple blood glucose levels, but using the long-term blood glucose level, which is known as HbA1c, or the hemoglobin that has collected sugar, so to say. So that prescribes your blood sugar level in longer time. That prescribes how high your blood sugar level have been during the last 3 months or so. Then if you have this level more than 47 millimoles per mole or 6.5%, only that one number gives you the diagnosis of diabetes. And if you have met this criteria once, you have diabetes. It might be in remission, which means that your blood glucose numbers are normal again, but still the diagnosis is still there. And out of our about 5.5 million people, about 1 in 10 or 500,000 people have diabetes. So it's very common. And of course, majority of them has type 2 diabetes. I have been told that my audience today knows the basics about diabetes, so I won't go into detail, but I just want to remind us all that type 2 diabetes means insulin resistance, and it is most often it's linked to obesity and lack of exercise and older age. So most of our diabetics, about 75 to 80%, have this type 2 disease. So that means they are probably older in age, maybe have higher BMI, higher body mass index. But also we have quite considerable amount of type 1 diabetics as well. And type 1 diabetes, it's very common for all health professionals here in Finland, because for some reason, probably due to our genetics, type 1 diabetes is more common in Finland than in any other country, because about 1% of our population has this disease. And to remind us all, type 1 diabetes is totally different from type 2, because in type 1 it's autoimmune disease, which means that our body is attacking the cells in our pancreas which make insulin, the hormone that is making our blood glucose levels normal. So if there is no insulin, like what is the case in type 1 diabetes, then the blood sugar level will go high, very high, and this disease, it's lethal if not treated with insulin. So that's one important thing to remember, that type 1 diabetes and type 2 diabetes, even though in both cases blood sugar level goes high, they are totally two different reasons between them. And here I have a small chart showing that unfortunately our diabetes, it's not the amount is not going down, but it's going up. So here is prevalence, how many % of our people in Finland have diabetes, and these are years in here. So with time going forward, we unfortunately see that the amount of male and female diabetics is going up and is about 10% right now. And as I mentioned, that the number of the people who deal with this disease is quite high in our country, so is the cost. And by cost I mean money, the amount of money we use in Finland because of diabetes every year, and also the human suffering and the loss of good quality years in people's lives that cannot be measured with only money. So this first, let's talk about money. Cost of diabetes, it includes, of course, healthcare, for example, the hospitals or the clinics or the people working there, doctors and nurses, also medicine used to treat this disease, but also what it costs for the patients to be absent from work because of this disease, or maybe they have to retire from their work earlier because of this disease, or they might need someone to help them, to assist them, and this also makes costs. And I wanted to compare the sum we use is 6 billion euros per year. But to compare, to make it more easy to grasp what it means, it's about the same amount of money that we use here in Finland, our public money, for our public schools every year, which means children's schools from 1st to 9th grade. We use as much money to that as we use to diabetes. So that means that diabetes is a very big, also economical issue in here. And of course, the better you treat this disease, the lower the costs will also be. And this picture here, it shows what brings the costs. As we know, diabetes in itself doesn't necessarily make that many symptoms right away. Blood glucose level that is a little bit elevated, it could cause like thirst or fatigue, but it might not be that much. So that's why many diabetics in Finland, they go they haven't been noticed yet, or they haven't been found yet. We haven't given them the diagnosis because they don't know they have any symptoms, and they don't go to lab test to have their blood glucose measured. But even when diabetes doesn't give you any symptoms yet, the high blood sugar in your bloodstream is already causing havoc or making problems in your body. And this is what brings these complications that might be only seen years and years later after the onset of diabetes. That's what makes the suffering and the poor quality of life and the health problems and also the costs. And there are complications that are life-threatening right away, such as the blood vessels in brain are affected, or the blood vessels in heart, which can cause, of course, to stroke or heart attack. But also in small vessels, in small blood vessels, there are effects that will be problematic with time. For example, nerves in periphery and foot problems. So these might cause for some long-term lacerations, problems, wounds in your foot, and might even end up in amputation of the leg. A second thing is kidney damage, which also comes quite slowly and can go unnoticed for years. And it can cause the need of dialysis within time. And eyes. Eyes have very small blood vessels, and that's why diabetes affects the bottom of the eye so easily. And as time goes by, that can cause even blindness. So, how do we then deal with our healthcare system? How do we organize healthcare system in Finland? In 1972, so more than 50 years ago, in Finland a law was passed that every citizen in here has right or has appointed publicly funded primary care clinic, and also possibility for publicly funded hospitals, which means that these things that have been noted here as pictures, which I will explain in just a few seconds, they have to be available for our citizens, not totally free, but with reasonable pricing, which means that whether you are rich or poor, you have access to these public health clinics, which I will just prescribe. So first of all, hospital fees, they are for the patients. Like I said, it's not totally free, but it's reasonably priced. So if you are really sick, you don't really have to think, can I afford going to hospital? There will be, and there are also systems, if you have totally zero money, that they will help you even with the reasonable costs or fees. So hospital is one of them, and this means ambulance and first aid. This means doctor's appointments or nurses' appointments in healthcare center, just like the one where I work. also home care, for example, for elderly people who cannot feed themselves or take care of their medicine. They will get help, outside help, home for these things. And this means alcohol and drug abuse clinics, where we help those who have these addictions. This means mental health clinics, mental health care. This is follow-up for different people and age groups. For example, all the 50-year-olds have opportunity to get a health check. This means nurse or prevention clinics, which help, for example, people who are dealing with high blood pressure or problem with obesity. This means prenatal care and also small children's care. This is school, so school clinics, school nurses, school doctors. This is dental care, and this means vaccinations. So all these things are by law available for every citizen, either free or with reasonable fee. And as I mentioned, that I will be talking a little bit about where the money comes from. It's funded mostly by government, which means taxes. It's us who work, who pay taxes, who pay majority of this healthcare, and a small amount comes from the patient themselves as fee. And these days it has been organized, this social and also healthcare system, within 21 well-being service counties. So they are larger than a single city or single village. It's a larger area, which but the Finland has been divided into 21 areas for this matter. And these well-being service counties, they receive the money from government, from taxpayers' money. And in addition to this, because this is available for everybody, and it can lead to quite long waiting times. So it's normal in my clinic, in my healthcare center, that if you call us and let know that, okay, you need a doctor's appointment, we might have the next time for non-acute disease available in 2 months. The lines are quite long. So this leads to that. Those who have insurance or those who have money, they might go and seek help from private sector, which means they pay everything themselves. Or many employers, they offer occupational health for their employees. And that also covers some, for example, of our diabetes care, this occupational health and also private sector. But now I want to address diabetes again. So the care and follow-up of diabetes, since I already mentioned the type 1 diabetes, which is a little bit like special thing in our country because we have so many patients, I want to tell about type 1 diabetes care and follow-up at first. Since this type of diabetes, which as reminder causes a very rapid rise in blood glucose level because of the lack of the insulin hormone, it usually starts at a very young age and leads to problems really fast if you don't treat it properly. More complication, higher mortality rate, and that's why we treat type 1 diabetes with extra care, and the cost of the medicine and the cost of the care is covered very well for the patient. What I mean is if you are on insulin medication, if you have to inject insulin into your body every day because your body isn't able to make this hormone itself, the cost of insulin hormone is covered 100%, which means that the patient don't pay anything themselves. It's all from government money, which covers the cost of the insulin hormone. Also, we have created these centers of care of type 1 diabetes, like the one where I work, where I mentioned that I work 1 day a week in a diabetes clinic. So this is the kind of clinic I mean. It's like multi-occupational, which means there are doctors and nurses and other professionals working there only for type 1 diabetes patients for their help. And also the equipment needed for care of this disease, it's covered 100%, with which I mean the measures to take measurements of your own blood glucose level at home. It can be either stinging yourself with needle and then taking the blood sample and measuring it with a meter. But for type 1 diabetes, we actually use mostly monitoring, which goes like under your skin, which you change every 2 weeks. So this device we give for patients for free, because that gives them possibility to monitor their own blood glucose level and react to changes very fast and many times a day. And we have found that this improves their self-care. So the thought is that because this type 1 diabetes, it's a disease that leads to death or severe complications at very young age, if not treated properly. Everybody has to have access to care, whether poor or rich. So that's why the cost is covered almost 100%. Okay, and now let's move from type 1 diabetes to type 2 diabetes, which is probably the more common in your country as well. And this type 2 diabetes is the one which starts at older age and which is usually linked to obesity and maybe physical inactivity, and it's not as aggressive usually than type 1. So type 2 is more varied, and some patients we see they might even have gotten the diagnosis, which means they have had blood glucose level above the threshold. So they get diagnosis and then they get maybe only one oral medicine and they are fine. Their blood glucose level will be normal for the rest of their life, and it's, so to say, easy diabetes. And of course, for patients like this, we don't need to be as aggressive as in care and in follow-up as in some other patients. Because in type 2 diabetes, we might also see a patient who gets this diagnosis, just like the one I mentioned just before, who has, so to say, easy disease. But the second patient might need a second oral medicine, maybe third oral medicine, because the blood glucose levels, they are not managed with only one or two medicine. and we might even see that they need insulin in the matter of a few years. And of course, this kind of patient, they need more care and they need more attention. Even though the diagnosis is the same, type 2 diabetes, the patients might be very different. And we have to be able to find out who belongs to which group, who do we need to monitor more closely, and who might not need as much attention. So, usually, if a person gets a diagnosis for type 2 diabetes, they are treated in healthcare centers just like the one where I work. And they are managed by GPs or general practitioners, family doctors, and nurses. And with this, I mean that there is no need to refer them to internal medicine, not to hospital clinic. In some countries, all diabetes is cared by like internal medicine professionals and in hospitals. But in our country, most of diabetics, even who need insulin, type 2 diabetics, their care is in their local healthcare center. And just like in type 1 diabetes, where I told that we give the equipment, we also give it in type 2. We give the blood glucose meters and the strips, and then we decide how often they need to take their own blood samples, and then give the strips as much as needed, not too much, not too little, and they are provided for them free of charge. And also laboratory tests are taken either once a year or twice in 2 years, or sometimes even twice a year when we are adjusting the medication. And these blood tests, they include at least this HbA1c, which is the long-term glucose level of the blood, and the lipids, which means like cholesterol levels, and kidney function tests are very important, both from blood and from urine, and sometimes like the picture I showed earlier, where does diabetes affect? There was the picture of the heart, so sometimes we need to take the ECG as well. And for their care, if everything is going smoothly, they might meet with a nurse once a year and with doctor only when they get their medication, and if everything is not going well, if we need to adjust the medication. And talking about medication, the cost of medicine, it's covered with like government money or with this taxpayers' money, depending on the medicine, from 40 to 100%. So even if you have type 2 diabetes, but you end up needing insulin, then the cost of the insulin is like zero for you. So the cost of the insulin is covered 100%. Nevertheless, if the diagnosis is type 1 or type 2, but the oral medicines, the tablets, they are the ones that don't have 100% coverage. You have to pay some of it yourself. And I wanted to address this one special area, which is called Finnish Diabetes Quality Registry. And this is something we have created in order to learn how our diabetics in Finland, how they are doing, how they are they receiving good and proper care in all of our country, and in all well-being service counties, in all of these 21 I mentioned earlier, or are there some areas or some diagnoses that are not doing as well in this diabetics population. And this I find very exciting, and I want to describe it in a more detail. So, as I said, it's registry, which means that it's a system that collects data about diabetes diagnosis, about medicine that has been prescribed for diabetics, about complications that happen to diabetics, about laboratory test results, and other things. So basically what it means is when a patient comes to my office or to a nurse's office, we always write some kind of report after the appointment. And there it is required, and they follow how often do we use the diagnosis code. We have to add diagnosis code every time. So when we add code for either type 1 or type 2 diabetes, this data can be collected from database. And along with this diagnosis number, it can be collected how often do these patients with diabetes go to lab, how often do they have their lipids, which is the cholesterol levels, measured, how often do they die earlier than other people in their same age, in their same area, for example, which medicine are they taking. And this data has been collected widely since 2018, and it gives online report which is open on the internet for anybody to read about many variables, which I will show shortly, twice a year. So the data, we receive new data twice a year about diabetics. And this data, this registry can be used to follow the quality of care of our diabetics. And if the quality of care, if it's getting better or if it's getting worse, and different areas can be compared. And now I will show you some examples. This is something I just yesterday got from the database, from the internet page. This is a standardized mortality ratio in type 2 diabetics in Finland. So this compares how our diabetics are more likely to die compared to other people without this diagnosis in different well-being service counties. This red dot is whole Finland, so it is 1.3 times as likely or more likely for a diabetic to die at
Okay, ladies and gentlemen, sorry for the inconvenience, but we still work on it. Maybe the operator can. Or someone please tell the audience what's happening now. Why the video is stopped.
Sorry, Mr. Faizar, the signal is low in this.
Yes, sir.
Yeah.
Oh,
Wait a minute for the committee.
okay, okay.
Okay.
Ladies and gentlemen, we're still working on it. Please wait. I guess we still have to wait for the video. Maybe a couple minutes more until it's done. Well, we are very sorry to inform you that we can continue the second speaker, but make sure if you want the material, we can send you the material because we hand the material right here. But it's really interesting to know that Finlandia have such a grateful management about diabetes. It's all free, even that we have to pay for the tax, but all the people there have a free um for diabetes curing. Okay, like it's a great presentation video and all of this explanation by Mrs. Thea. We learned so many things about dealing with diabetes with different point of view from Finlandia. Yeah, it's really different with Indonesia. But we do learn how Finland organized the healthcare and how they manage people with diabetes mellitus it really gives us such an inspiration. Hopefully we can like Finland one day. I mean, and, and if you have any question, please keep it until the Q&A session. Hopefully Miss Thea will join us soon. Ladies and gentlemen, now it's time to hear from our third speaker. We'll wait for the operator share the CC of the third speaker, please. Or if it's unavailable, because the operator just lost the, okay. As you can see, ladies and gentlemen, just so you know, he is a speaker and guest college of Majelis Agama Islam Wilayah Persekutuan Internasional or UCMI Malaysia. Please join me in welcoming Mr. Muhammad Ashraf bin Saleh. Hello, Mr. Have you guys check? Hello, Mr. Ashraf.
Hello, can you hear me?
Oh, okay. Yes, I can. Okay. How are you doing today, Mr.?
Alhamdulillah, I'm doing fine. Thank you for your invitation.
So, ladies and gentlemen, the presentation title is Integrating Faith-Based and Community Engagement Strategies in Diabetes Mellitus Type 2 Prevention. It's a lesson from Malaysia and will be delivered by Mr. Ashraf. Let's cut to the chase. I'll hand it over to Mr. Ashraf for the presentation. Please, Mr. The time is yours.
Thank you so much. Assalamualaikum warahmatullahi wabarakatuh. And good afternoon. First of all, I would like to thank to our organizer. It is my honor to present for this topic. So, lesson from Malaysia, integrating faith-based and community engagement strategies in type 2 diabetes mellitus preventions. So, from the morning, I already heard there's a very interesting topic, and for my part, so there will be integrating between the faith-based and also community engagement. So, thank you to the committee for share the screens. This presentation will draw on insight from both national programs, especially in Malaysia, and scholarly studies conducted in Malaysia. The goal is to highlight how faith-based and community-driven initiatives can serve as powerful instruments for promoting sustainable diabetes prevention and management. So particularly in our Malaysian country, because our Malaysian country is a multicultural society. So for the second slide, yes, thank you. So to begin, let us look for the global and Malaysian diabetes burden. So as we know, so previous presenter also already present that 1 in 9 adults globally has diabetes from the IDF data. Globally, so we know that within the Southeast Asia, Malaysia ranks among the highest in prevalence for type 2 diabetes mellitus. So it's a very worried situation in Malaysia, because we know that this pattern that continues to rise annually. So there's a very challenges in our Malaysia, because we have a lot of food that become the challenges. Currently, we have a lot of coffee shop. Okay, as we know, in Indonesia also, we have the Zeus, we also have the Mishwe, and also there's a very challenging. Okay, and the people in Malaysia still they have awareness, but still practically they do not follow how they want to take care about the blood sugar. So there's also rising cases, okay, studies by as those by T and Yep 2017 and also Ibrahim et al. So sorry, previous slides, please. Sorry. Okay. So this attribute this upward trend primary, okay, because this is causes by the lifestyle related factors, healthy dietary patterns, sedentary behavior, and urbanization. Sorry, for the second slide. Still, for the global. Lisa? Previous slide, previous slide. Oh yes, sorry. So the rapid rise in type 2 diabetes mellitus is closely linked to the lifestyle factors, okay? Because this is particularly concerning is the growing number of cases among rural and low-income populations where health literacy and access to preventive care are often limited. So therefore, it is increasingly clear that community level engagement is not merely supportive but essential to prevention. So I will present to explore how both faith-based and also community engagement approaches can strengthen the country diabetes prevention and management frameworks. So we know that health behavior does not exist in isolation. It is profoundly shaped by the social and also the cultural context. So based in these faith-based and community groups influenced by norms and also the lifestyles. In Malaysia, religious and community organization hold strong influence over daily life values and norms. So thus integrating these elements into public health intervention can foster more holistic and sustainable prevention efforts. So it is important to clarify that faith-based does not equate to the religious preaching. So rather, it refers to the use of the shared values. Faith-based is not equal to religious preaching. And also, within Malaysia multi-ethnic society, so faith institutions play a pivotal role in the shaping health behaviors and attitudes in Malaysia's multi-ethnic society. So why these two need to combine? Okay, because the rationale for adopting faith-based, okay, because of the spiritual and also social participation. So next slide. Okay, as mentioned, health promotion succeeds when it speaks the language of the community, both spiritually and socially. So this emphasizes that that successful health communication must resonate with the community's belief system, cultural narrative, and also social networks. So by engaging both faith-based and also secular community platforms, public health initiatives become more inclusive, contextually relevant, and sustainable. These partnerships allow prevention messages to be conveyed not as an external intervention, but also as an extension of local values and also collective identity. Okay, so for the next slide. So based on the Malaysian's community health landscape, next slide, please. lost. So in Malaysia, actually, we established a robust community health structure. So we have the rural area, we have the community clinic, or we call it as a clinic desa, supported by the volunteer networks such as COSPAN. COSPAN is stand for the Community Sehat Perkasa Negara. So the COSPAN program represent a nationwide peer-led initiative, okay, aimed at promoting healthy lifestyles and early disease screening. So we are at UCMI also have a lot of collaboration with the COSPAN because we focus on the low income people, okay, and also in parallel, so faith-based organizations, we also collab with the mosque because we are under Majlis Agama Islam Wilayah Persekutuan, so under the religious organizations. So usually we also do a lot of collaboration with the mosque. There's also in Malaysia, NGO collab with the churches, temples, often serve as a social anchors for community outreach. So we also serve as a vital social anchors. We host health talks, blood screening sessions, and awareness campaign to reach deep into communities where formal health system may have limited access. So we know that mostly the community goes to this faith-based organization, mosques, churches, and temples every day, every weekend. So what we looked at, we can approach the community to these places so that we can give awareness to them. Non-religious community groups, okay, such as women's group, youth group, also senior associations, and senior citizen network, so also play equally important roles. Their contribution demonstrate that effective diabetes prevention depends on community mobilization and multi-sector collaborations. So in my theoretical underpinnings, okay, next slide, please. So I suggest based on these three practices theoretically, three main frameworks. Which one? The first one, health belief model. For the next slide, please.
Mr. Vicky, for the next slide, please. Sorry for the inconveniences because we have some trouble here.
Okay, sure.
Yeah, it's a heavy rain here in
Okay,
Indonesia.
sorry. Okay, it's okay. So we know that we have collaboration. So this is my suggestion for these models. Okay, which the first models, how belief models, because we know that as a Muslim also, so we believe that behavior change when individuals perceive personal risks, recognize the benefits of prevention action, and also feel supported by their social environment. So they know that, okay, as a Muslim or other religions, so behavior change because of the personals. And the second one, okay, if I'm not mistakes, is a social capital theory, which is we emphasizing the trust, share norms, and also social networks within the communities, which can be mobilized for collective health improvement. So as a multi-ethnic country, okay, we have a different religion, but mostly all our belief and also all religion trust that we must take care of our health, okay. And the last one is about the faith and meaning system. So all of us have our faith based on the religion. So we know that we recognize that both faith-based and non-religious organizations provide essential sources of moral and social motivation. All have the same sources for the moral and social motivations. Together, these frameworks highlight that effective prevention depends not only on the knowledge, but also on the community cohesion, shared belief, and also the mutual support. So we know that, okay, we cannot separate between the faith and also the community. That's why this theory can go for the integrating part. That's why when we integrate faith based on the approach, okay, Malaysian provides several practical examples how faith-based approaches can be integrated into the community health promotions. So we know that, okay, as same with the Indonesian, so we have mosques everywhere. So I think there's a lot of us that can do a collaboration, and we do a lot of activities at the mosque based such as health screening programs, because we know that the mosque is a very easy when we want to gather all the community in one place, and then we can do many activities such as a talk, and also we know that people also go to these places, okay, to do a pray and so on. So at the mosque also, we often conducted in partnerships with the local health clinics. So when we call the hospital or the clinic to do the some awareness or activity, importantly, these clinics are open to all, okay, not based on the religion, but open to all the community, regardless of the religious background, emphasizing inclusivity rather than exclusivity. Also, we look for the universal moral values such as discipline. We know that all religion teach us about the discipline, compassion, and stewardship as a motivational tools for behavior changes. So this session frame healthy living not only as a medical necessity, but also as a shared social responsibility. Okay. Okay, this one. Oh, sorry. Previous slide. Previous slide, sorry. And the last part, we know that each of our religions, okay, at the mosque, at the church, and also the temples, we also can collect with the leaderships, okay, such as imam or church leaders. So we know that they can play vital roles who endorse the physical activities, okay, and also healthy eating during community events. So based on this leadership, and also we integrate with the community, we also can do a lot of activities that can be on their collaborations. So through this collaboration, so faith institutions become a partners for prevention, reinforce public health messages within the moral and social framework familiar to the community. Okay, next slide. So in parallel with these faith initiatives, we also can look for the non-religious community organization or NGO, which has or have also proven instrumental in addressing diabetes preventions. So for the next slide, okay, for instance, as example, women's group, okay, such as Kumpulan Wanita, okay, or housewives associations, okay, often organize healthy cooking demonstration, emphasizing low sugar and balanced recipes. These are complemented by peer-led awareness sessions with the local nurse using storytelling and also the food sharings as effective informal teaching tools. They also can collab with the influencer, okay, so that we know that we can attract all the communities, and also we attract to the faith-based places and so on. So we can do collab for the talk and so on. We also have the Village Development and Security Committees, JKKK, okay, Jawatan Kuasa Kampung, integrate health promotion into existing community meetings, activities such as gotong royong. Okay, as previous speaker also said, as a gotong royong is a very healthy clean-up events, okay? So we can combine with the physical exercise, with the social participations, and also strengthen both community bonds and also health outcomes. And also for the youth club and NGO at the previous slide, sorry, okay, have also emerged as creative agents, change organizing campaigns, social media challenges, community competitions, okay, healthy village challenges, and also on. Okay, we know that the mostly of our influencer and also is youth, okay, so they can attract, okay, to do the activities, okay. They also based on the religion influencer can also call on the community to do a creative agents of change. And finally, we have a Cospan Health volunteers, the backbone of Malaysian peer-led health movement. They also can provide continuous follow-up, the weight and glucose monitoring, and also the motivational supports. This based on the comparison of two Malaysian studies on diabetes self-care. Okay, we have the Saidi et al. And also Nebra et al. 2018 and 2019. Both focus on the fatalism and faith and also the beliefs, which is they study at the urban Malaysians and the other studies at the multi-ethnic population. So they have do the interview and observation and also the focus group discussion. So as the findings, okay, they found that okay, mostly in Malaysian people, okay, not mostly, but based on these findings, okay, for the fatalism, okay, diabetes seen as inevitable, and they know that illness as divine test face motivates acceptance and discipline. They know that when they have the diabetes, okay, they couple with the fear of the consequences of diabetes. So this motivate them, okay, to engage for the self-care practices. So they know that based on this study, the findings found that, okay, they know that when they got the diabetes mellitus, this is test from the God, okay. Allah memberi ujian. So they know that when they got the diabetes, this test from the God and also give they got the illness, but the test doesn't mean that they just accept the illness. They know that they need to fight and also to find the treatment for to cure their diabetes mellitus. And also the fear of complication drives compliance but lowers self-efficacy. There's faith. Faith provides emotional resilience and structure for self-care and balance fear-based education with faith-driven empowerment. So based on this the article and also by the study studies, so they know that in Malaysian also they believe that God also give their test to them and also they know that okay this psychosocial dimensions of diabetes management okay can be linked to the fatalisms, okay. But for the Neblet et al. 2019, okay, they look for the goals, belief, and barriers among Malaysian multi-ethnic population. So they have done the separate between the ethnics, Malay, Chinese, and also the Indian. So their findings highlighted that patients desire normalcy and minimal medications, yet many rely on both modern and traditional medicine. So they know that they believe in God, okay, but they also look for the modern and traditional medicine, okay. That's why they still have the faith to the God and also social and cultural context of ethnic differences in this shaping behavior. Okay, next slide, please. Okay, so actually we have a lot of programs. Okay, this is one from the Masjid Wilayah Persekutuan at the KL. Okay, so they do the several activities. So this one of them. Okay, they know that in mosque, okay, they have a large of huge place, so they can do a lot of activities. Okay, such as a program Jom Fit Sehat dan Cergas. Okay, this one of the example. They also do a lot of activities such as healthcare screening and so on. Okay, next one. Okay, from our university, UCMI also collab with the mosques, okay, several mosques, okay, around Malaysian, okay, we do the health screening, so we know that, okay, rural area, okay, rural people also mostly they going to the mosque, okay, so in the same time, we want to look that when we do a collaboration with the mosque, we also have done the medical screening and so on. And also not as a Muslim, okay, for the next slide, okay, because they know that when they have disease, okay, when they have the type 2 diabetes, okay, so we want to rely on them, okay, because this is, we have a cure, not just they just surrender and doing nothing, okay. They also have experience, okay, in the temples, okay, and also at the church, okay, not only as a Muslim, but also for the others religion. Okay, for the next slide, from the clinic. Okay, so they collab with the temple. Okay, so challenges and lessons from Malaysia can go for the next slide. Okay, this one for the temple with the clinic Muhibbah. Okay, so several challenges, okay, remain. Okay, the first one, there is a limited long-term funding, okay, for grassroots and volunteer-led initiatives. So many programs begin with a strong momentum but struggle to sustain. We know that when we want to do a lot of activities, so we have a lot of funding that need. Okay, the secondly, okay, for the next slide, okay, volunteer fatigue and turnover, because this is not just from the clinic or the hospitals, but mostly from the volunteerism. Okay, so maintaining motivation among unpaid community health volunteers requires continuing recognitions, training, and also institutional support. Because we as a multi-ethnic country, so we also need to look for the cultural sensitivities. Must be carefully navigated because integrating faith-based values should never alienate individuals of different beliefs. That's why some of it must be inclusivity and respect the principles. And also the last one is the impact measurement, which is at the community level remains complex because quantifying behavioral and cultural changes requires both qualitative insight and also longitudinal data. Mostly we have just 1 year study, okay, not as the longitudinal study for up until 2 to 3 years. So something that current monitoring system still need to strengthen. So despite these challenges, the Malaysian model demonstrates that community and faith partnerships are indeed feasible and effective pathways for sustainable diabetes preventions. Okay, next slide. So there are 4 keys, takeaways, and recommendations, okay, from my part. The first one, okay, community engagement lies at the heart of diabetes preventions. Without community ownership, even the most well-designed health programs still fail to achieve a long-term impact. The second one, okay, we know that both faith-based and also the secular groups share fundamental strengths, okay, trust, connections, and also meaning. Okay, when these elements are harnessed collectively, prevention becomes not just a medical issue but also the shared social movement. Okay, so because we know that, okay, there's a very common diabetes in Malaysia, so we must know that must be shared the fundamental strength. And I agree, okay, with this topic. Okay, we need to integrate, okay, because integration is crucial, not isolate, okay. Faith, culture, and also community structure must complement formal health services. And lastly, empowerment over education. Okay, we know that empowerment must take precedence over mere education. Instead of simply delivering knowledge, okay, the programs should nurture self-efficacy and collective responsibility within the communities. So this shifts transform beneficiaries into active health advocates. Okay. So I think the last part is my references. Okay. So we know that so together this source is as based on our study in Malaysia. Okay. I think that's all from me. Okay. So as humans, we also need to try to find a way to manage and cure type 2 diabetes mellitus, okay, to treat ourselves. So we must integrate between the faith-based and also the community. So I think that's all from me. Um, I pass it to the moderator.
Yeah. Okay. Thank you very much, Mr. Ashraf. That was mind-blowing for informative presentations. I'm flabbergasted that that was wonderful to know that community engagement is really helpful in organizing the prevention of diabetes mellitus type 2. Health behavior shaped by social and cultural contexts. Faith-based and community groups influence norms and lifestyle. Integration foster holistic, sustainable prevention. Faith-based not meaning religious preaching. It's about shared values. Wow, it's wonderful. It just opened my eyes and of course all the audience. Faith in
Thank you.
religious institutions play a pivotal role in shaping health behaviors and attitude in Malaysia's multi-ethnic society. I guess this is also can be applied in Indonesia as we have so much in common, Mr.
Yeah,
Okay.
sure.
Thank you very much. Thank you very much. Ladies and
Thank
gentlemen,
you.
now it's time to open the floor for question and discussions. The committee have collected all your questions, or you just can ask the questions directly by raise your hand. Please, the operator, if or maybe I want to say hi to the first speaker, Professor Fendi. Are you still joining us? Thea, have you here joining us already? Because we got a question. Maybe the first for Mr. Muhammad. What about health workers who have different beliefs from diabetes? Can they collaborate in providing health services to diabetes patients using a faith-based approach? Do you got the question, sir?
Yes, yes. Okay.
Okay.
We know that we have different belief on the religion, but when we come to the disease, okay, such as for the diabetes mellitus, okay, let's have the same belief, okay. This is a very important considerations, okay, because in any multicultural or multi-faith setting, so the health workers may not share the same belief as their clients. So, however, okay, so we do not promote religious doctrine, but to connect through share values and respect for the belief system that influence their health behavior. So health workers, okay, regardless of their personal faith, play a critical role as demonstrating cultural competence, that is understanding, respecting, and working within the client's worldview. These approaches emphasize empathy over the endorsement. So we do not cross over based on the client belief. Okay, for example, as a non-Muslim health worker supporting a Muslim patient might frame dietary advice in the ways that acknowledge fasting practices or communal eating norms. So we know that we as a Muslim, we fasting, okay, during our Ramadan, but they respect that. And also, as a Muslim health worker, engaging with a non-Muslim client, which can focus on universal moral values such as discipline, moderation, and care for one's body, which are shared across many belief systems. So the goal is to build trust and mutual understanding, not to align the beliefs. So we want to build a trust for the treatment and also for the awareness. So when health workers approach clients with openness and also the respect, so it will strengthens communication and ensures that care remains inclusive and also ethical and also the effective. Okay, so when they can collab in the providing health services to diabetes mellitus patients using a faith-based approach. So usually we go to the mosque, we go to the church, but mostly uh, for my university, because my university under Majlis Agama Islam Wilayah Persekutuan. So usually we go to the mosque. Okay, there are a lot of the collaboration between the government, the mosque, and also our university. So when they have an event, okay, such as contohnya, okay, sambutan Maulidur Rasul. So we know that all the people will gather to the mosque. So in the same time, we as the university also have the responsibility as the health center. We go to the health screening and also have the talk, okay, and also have the some collaboration to explain about the awareness for the health system. So when we have a collaboration between our religious ministry and also we have the collaboration with the mosque, so this is one the approaches that we can do, okay, between the community and also with the university and also with the health system. So that's one of our example. Also same with the others religion, okay, some of the clinic and also for the hospital also go to the temples and also to the church when they have any perayaan ataupun any sambutan, jadi mereka datang ke masjid, ke temples. So we do a collaboration and also the health screening and also other talks related to the health. Okay. Am I answer the questions?
Wow, thank you very much, Mr. Ashraf, for the complete answers. I mean, when we're talking about disease, it's nothing to do with religions. I guess all religions, whether you're Muslim, Christian, Hindu, or Buddhist, we all have same belief that we have to be healthy persons as long as we know the limitations. Okay. So we don't cross the line. Okay, thank you, Mr. Ashraf. Maybe we still have another question, but before that, we still waiting for Professor Ferry Effendi. Hello, Prof. Or maybe Mrs. Thea Porella. Hey, Mrs. Thea.
Hello, hello.
Oh, it's right. It's really nice to hear your voice. Thank
Yes,
you, Miss.
thank you.
Okay, we got a question for you. Are you ready for
Thank you.
answer the questions?
Yes, of course.
Okay, let me read the question before. Could you share, based on your experiences, that Indonesia might apply in terms of caring in diabetic mellitus type 1 versus diabetic mellitus type 2?
Sorry, could you repeat the question? It was a little bit bad line.
Okay. Okay, I repeat the question.
Thank you.
could you share based on your experiences that Indonesian might apply in terms of caring in diabetic mellitus type 1 versus diabetic mellitus type 2? I mean, if there is any experience differences between both type of diabetes
Yes.
for Indonesia. Yeah.
Thank you. So from what I heard from my friend Laura Raisane, who has good experience in Indonesia, she's also a doctor. I heard that it's very rare, this type 1 diabetes, which is the lack of the hormone insulin. This type of autoimmune disease form of diabetes, that it's very rare in Indonesia. Am I right? That type 2 is what when an Indonesian hears about diabetes, it's type 2 diabetes they most often think about, right?
Yes, Miss Betul. That's right.
Yes.
That's right.
Yes. So I think it's extremely important to remember the possibility of type 1 diabetes and bear in mind that these two diseases, they are, even though the representation is the same, which means that the blood glucose level is high, the reason and the treatment are totally different. And therefore, it's important to bear in mind that when you see a patient with diabetes, especially when there is something abnormal about it, the patient might not be obese, might not be old, or might not be responding well to oral medication, then you should bear in mind that this could be type 1 diabetes, and bear in mind that in this case the doctor or the team has to be more aggressive and think about insulin hormone in very early stage of the treatment. So let me give you an example about my own country, about Finland. For example, we have a lot of chronic lung disease, but there are some types of lung disease which are like COPD, like emphysema, that are not caused by cigarette smoking or pollution. There is also a type of emphysema that is caused by genetical issues, and it's the same. We see it very rarely, but when we see a patient with emphysema that is not responding to treatment as is supposed, or as would be weighted, we have to bear in mind that, okay, this might be the genetic type of emphysema, and then we need to think, for example, for the whole family, and think about the family history, and sometimes even testing the family for this same disease. I wanted to give that example because for us, the almost all emphysema patients who we see are not like because of genetic reasons, but sometimes 1 in 100 or 1 in 200 might have this, and we have to keep it in mind so that we don't miss that person. I hope that this was this gave you some new information and something to think about.
Thank you very much, Mrs. Thea. So, which one is the worst, type 1 or type 2?
I would say that type 1, that's a simple question. The type 1 is worse because without treatment, it leads to death in some months. Because without, if there is total lack of hormone insulin, that leads to very high blood glucose level very quickly, and a person can live with insulin for only some months. Like hormone insulin came to Finland 100 years ago, about 100 years ago, and before that, this type 1 diabetes, it was totally lethal. with some like food restrictions, the type of diet where it was really restricted the amount of carbohydrates a person could survive for some months, but that was it. And they would lose weight, and then they would just slip into coma and die eventually. But as we know, with patients with type 2 diabetes, with even with diet changes and with loss of weight and with exercise, we can reach normal blood glucose levels even without medication. Of course, usually we need medication, but even with medication, this type of diabetes can be managed, and it's not usually as fast in progression as type 1 diabetes. So my answer would be type 1 diabetes is worse, but of course sometimes type 2 diabetes, when it's not treated properly, when the patient doesn't adopt the lifestyle changes or the medicine is not available, it can lead to same kind of situation than type 1 diabetes.
Thank you so much, Mrs. Thea Furela. How do you spell your name? Am I correct?
Yes, it's very, very good pronunciation.
Thank you very much. I guess your answers are really good because you are diabetologic and for a bunch of experience. So yeah, type 1 is worse than type 2, but hopefully we don't have that in our life, especially for type 2. And thank you very much, Mr. Thea. You can still hear. Wait, maybe there is another question for you, but we are going to Professor Ferry.
Thank you.
Hello, Prof. Maybe the committee can inform the Professor Ferry Effendi to join us again, to rejoin us here, because he got a question here. But what if he jump to the next question, maybe for Mr. Ashraf? I guess there's a lot of question to Mr. Ashraf because it's quite interesting since he explained about faith-based approaches. The committee, the operator, can you show the other question maybe on the screen?
Okay.
Oh.
Sorry, bisa untuk saya. So I can answer for my part.
Wait, on the chat box, maybe Mr. Ashraf, on the chat box you can read maybe, but in Indonesian languages.
Okay, tanggungjawab government.
Apa?
Dalam
Betul.
Yeah. Okay. So in Malaysian, we have the Ministry of Health, okay, MOH, Kementerian Kesihatan Malaysia. So this ministry holds the primary responsibility for expanding public health and community service. So this MOH operates through various divisions. So MOH have a lot of divisions such as public health divisions and also such as family health development, disease control, and so on. So all of these divisions coordinate national strategies on the prevention, health promotion, and also primary care. So based on the differentiation between the health clinics and also the community clinics, so we have the health clinics or hospitals at the urban area. So in the urban area, so we comprehensive primary care center for the doctors, nurses, and also the others allied health staff. For the community clinics ataupun dipanggil sebagai klinik desa, okay, smaller rural-based clinics So usually run by the community nurses or the assistant medical officers. So when the rural people have the problem with their health, so the first thing they can go to the clinic themselves first, go to the community clinic. If they cannot solve a problem, they need to refer to the bigger hospitals. They can go to the health clinics at the urban area. We also have a mobile and outreach services, okay, which is we remote or undeserved areas. So the community clinics, this clinic that's supervised by the nearest health clinics and fall under the district health office ataupun kita panggil sebagai pejabat kesihatan daerah, which is reports to the state health department, to the local authority. So the health clinic, on the other hand, offer the wider range of medical and preventive services, including outpatient care, chronic disease management, laboratory services, dental units, and also the emergency care. So it is staffed by the medical officers, nurses, and also the health professionals. So that's a different, okay, between the rural area and also with urban area. So rural area we call as clinic desa, and then for the rural area, sorry, for the urban we have hospital or district hospitals. So I hope that answer the questions. Yeah.
All right. Thank you very much, Mr. Ashraf. Yeah, for the answer the last questions. Okay, maybe for Professor Ferry, Mrs. Tia Valera, PhD, and Mr. Muhammad Ashraf bin Saleh, PhD. This is the last questions, as we have at the end of the time, because it's already in Indonesia. It's 15 25 minutes, so we still have 30 minutes more. But before we end this, for the speakers, Professor Ferry, Ms. Tia, and Mr. Muhammad Ashraf bin Saleh, we have appreciate you with a certificate. Maybe for the operator, can you show the certificate first?
Okay. Yes, Ashraf.
Sorry, mute, still mute, Dr. Ashraf.
Yeah, this is the certificate for Professor Dr. Effendi. Thank you for sharing with us today. And this goes to Dr. Tia Valera, PhD, as a speaker. Thank you very much for sparing your time to talk with us, to sharing insight with us. Thank you very much.
Thank you. It was my honor. Thank you very much. I really appreciate this.
And last but not least, this is for Mr. Muhammad Ashraf Saleh, PhD, as the third speaker. This is a certificate for you, and hopefully we can meet forward. Thank you very much.
Okay, thank you so much for the invitations.
Okay. All right, ladies and gentlemen, apparently we're at the end, so let's call it a day. Thank you all for your participation and engagement in today's seminar. Before we wrap up, does anyone have any final comments or questions? I'll count it 1, 2, 3. If not, I'd like to thank you to our guest speaker once again for their valuable insight, Professor Dr. Ferry Effendi, PhD, Mrs. Tia Varela, PhD, and Mr. Muhammad Ashraf bin Saleh, PhD. We hope you found this seminar informative and useful, and we look forward to seeing you at our next event. Have a great day. Assalamualaikum warahmatullahi wabarakatuh. I'll pass it to the MC.
Waalaikumsalam warahmatullahi
Waalaikumsalam warahmatullahi
wabarakatuh.
wabarakatuh. Thank you, Mr. Fajar.
Thank you, Mr. Fajar.
Anytime, sir.
See you tomorrow.
Saya Asraf and Dr. Ferry, Prof. Ferry. Siap. Ya Pak. Sampai
Thank
jumpa
you.
besok. Masih banyak.
What an amazing session. On behalf of the committee, we would like to thank all the speakers for sharing the amazing presentation, and to Mr. Faizar Wahyudi, SCAP Master of Public Health, that has been leading this session very well. Ladies and gentlemen, we have come to the end of main session for today's international conference. But before I close today's event, I would like to inform all of you that there will be an expert session and oral presentation on the second days of our international conference. On behalf of the committee, I would like to thank all the participants as well as the speakers and also the moderators for all enthusiasm in participating in our international conference. We would also like to apologize for any major or minor inconveniences. Hopefully, this session will be a great benefit for all of us. It's been an honor to be among such accomplished individuals and to be able to host every individual today. On behalf of the entire team, thank you so much for joining us. Have a wonderful day, and we'll see you tomorrow in the second days of the conference. Until then, stay curious, stay engaged, and take care. I'm Surmita signing off. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Para itu
Berikan 400 orang. Ini berapa 400? Oh iya. Bukan 400, 4 per 9 per 8. Mana begini?